prosthetics. And the other thing is EHR, electronic health record, is a systemized collection of patient and population electronically stored health information in a digital format. And this is going to be a big boom in our management of patients. And the mobile health is another one without any cards or wires. The patients are connected. Telemedicine is the end product of most of these, where we incorporate most of these technologies in the telemedicine in the patient management. Just to show you, look at these various sensors available now. Eyeglasses which can detect your glucose. There are contact lenses which can detect your glucose. There is the microfluidic sensor which can again detect glucose, and integrated sensor array. You can see the watches, the wearable diagnostics which can include various aspects. Now this just to show that literally your heart rate, your ECGs are seen with your Apple watches, as you are aware right now. There are ground reaction force sensors. There are wearable jackets, just like you wear your jacket, you wear for a Holter monitoring. It's already approved. Next year it is going to be launched. There are already CGMs, ABPMs where remotely you can get data on your mobile phone, and there are glucometers also. So just to introduce the information and communication technology, what we commonly call as IT, and it is incorporated in all the sectors, I'm sure. It has transformed the way healthcare data is managed. So the widespread usage of these electronic gadgets has put us the availability with the availability of high-speed internet have made possible the transition from paper-based patient records to electronic records. So this IT has created a paradigm shift in the way we handle our patient clinical data, store them, and use and disseminate them. And evidently, there has been a gradual shift from paper-based to electronic records, and these are called in various names. EMR or EHR is one of the commonest, electronic medical records or electronic health records. Now, India is embarking on a journey towards providing universal health coverage through various government schemes. We know that through a multi-pronged approaches of reducing the catastrophic out-of-pocket expenditure for our patients. And it is envisaged that the health information technologies that we call HIT or digital health would create enabling environments for addressing some of the systems level challenges in healthcare delivery. Sorry. An electronic medical record, what is the definition? It's a unique longitudinal electronic record of a person's health over life course that comprise of patient's demographics, progress notes, clinical problems, medications, past medical history, lab attachments, etc. And it can be accessed instantly, securely by authorized users. That's the most important. Instantly and securely it can be authorized. So this is what it comprises of, the EHR system. Now, the benefits of EMR are manifold. Some of them, they ensure the records are easily accessible anytime, anywhere. It can be stored easily in less space. Being in electronic format reduces the number of records lost, improves the quality of patients' records, are cost effective, helps to track patients' clinical progress, gives a summary of reports, and even artificial intelligence can be incorporated into that. We can give graphical representation of the same, like a HbA1c or a fasting sugar or a height, weight of the patient over a period of time. It helps to improve the accuracy and speed of diagnosis. It can be transferred easily within and across the healthcare facilities, like in a given hospital, across specialties can view the same patient with a single ID. It's easy to update and can be available to be used by multiple users, allows keeping backup of patient's record at a very low cost. EHR facilities improve healthcare decisions and provide evidence-based care, and it can be used for research purposes, very, very important. So eco-friendliness, saves paper, reduces time, and the strong database for research, and there is an e-education or training which can be done online again. Now, this is the advantages. Now, what are the challenges faced by Indian healthcare establishment in the implementation of this electronic health records? Of course, the barriers preventing technology adaptation by HCPs are manifold. As you can see here, these are the questions asked by HCPs. The tens and thousands of apps are available. How do I choose? Do my patients have a role to play in this technology? What would my patients want or need digital health? And these are all the various questions asked by healthcare very, very commonly. Wearables can produce a lot of data. How can I manage this? How do I use this technology? Where's the evidence for using digital health solutions? These are all the various questions asked by the HCPs. Now, the key challenges include the success of electronic health records relies on the acceptance by the clinicians. And because of the various patient loads in most of our OPDs, it's a key barrier to use this, because if you're not tech savvy, you're not going to be liking this. Lack of common understanding between the clinicians and the software development teams. So there has to be coordination when you design an application. Hospitals tend to focus primarily on the billing and revenue cycle. I'm sure all of you agree with this. Most of the corporates do this. And Thus, the technology solutions are deployed only to address the billing and revenue cycles rather than incentive to the clinicians. Now, loss of face-to-face interactions due to technology disrupting the clinician's-patient communication is a major drawback of these EHRs. Not engaging with the end user, that's the patient involvement is not there. And most EHRs do not consider the patient behaviors into the design process, unlike in the past. Now, the many patients are technology savvy, maintain their treatment-related records in electronic formats on their mobile phones, etc. So you have to incorporate them also. There are no mechanisms in most EHRs which allows the patients to contribute their valuable clinical and treatment related informations into the healthcare delivery systems. Healthcare in India is provided in a multilingual context. However, most EHRs lack these multilingual capabilities, language barrier. And fragmented multi-specialty approach is another hindrance for the EHRs. Unwarranted repetition of investigations, thereby increasing the financial burden on the patient healthcare systems, especially when it is involved in many verticals like a tuberculosis control program, vector-borne diseases, NPCDCs. All these will collect various information and similar data is collected repeatedly, and this may be a cost burden onto the patient. Now, the common electronic data repository will sort out all this. Better interoperability of these systems should be there, and lack of any incentives for the clinicians for using EHR, like there should be some encouragement incentives in a corporate setup or in an outpatient setting that makes them to accept very easily. Specific challenges, relative lack of computer literacy, poor change management practices, lack of uniformity in EHRs, lack of synergy between the healthcare providers, resulting in non-interoperability or data hugging, what we call, lack of operating system in the EHR, lack of awareness, the no mandatory requirement. That is all these makes a person that is a physician to not to use these systems. So time needed to install, train your staff, hardware, network issues, electricity, learning curve of the office staff. That's very, very important because your office staff has to be equally learned when it comes to handling the EHRs. The computer may act as a barrier between the patient and clinicians, security and safety issues. These are all the things which we need to look at when you choose a particular application for management of the records. And initial buying cost, prescription and local challenges, QR generated codes are available, after scale services in the process, can it be used in mobile or laptop? All these questions are rightly pointed out. There are a lot of physicians like Dr. S.V. Kulkarni, who does a lot of work in this electronic and educating people, and he conducts various workshops in a lot of conferences. Now, overcoming challenges. Now, what are the solutions? Obviously, we need to sensitize healthcare workers on the importance of EHR, introduce data science and health informatics as a part of curriculum in medical and allied health subjects. This is the most difficult task because as soon as you come out, it's like reading ECG. During MBBS, nobody teaches us to read a ECG. When you join MD, you're expected to know the ECG. It's something like that. So there should be a synergy between healthcare professionals and software developers. A national repository is something which is a welcome move, like in NHS in UK. Utilize open source operating systems and tools for developing EHR, and use standard clinical workflow guidelines, and including clinical workflow guidelines for developing EHR solutions should be formed so that everybody are in the same page when it comes to the use of EHR. And use to improve usability, natural data input such as handwriting, voice could be considered in the EHR, because most of us are the typing may not be very fast. So we can incorporate this handwriting or voice enabled things so that it automatically transfers into the digital. Sensitization of the workforce through training of doctors and nurses. Patients should also demand implementation of EHR. That's from the patient's side. This might be a step towards putting the person at the center of the healthcare delivery system. Now, we'll skip this for want of time. Now, relevance of emerging technologies is, example is being a mobile phone and internet-based messaging platforms. Unstructured data sets could be leveraged to build health data repositories across the country. Citizen Digital Locker, which is something launched by the government, could be another potential resource for citizen health, personal healthcare record, or portable EHR. So, way forward, we need to improve the usability, user experience of EHR, such as incorporating voice-based inputs, handwriting inputs, natural language processing and machine processing, learning techniques for clinical coding, decoding, contextuality of augmented clinical decision support systems. Data is an emerging currency equivalent. Please remember that. The more the number of data you have, the more the value going to be in future. And India, our country, has a potential of becoming the global capital of this ecosystem because we are very good with the IT. To conclude, the development and implementation of EHR in India are still in the fragmented state. In this journey, a national standardized EHR may be the first step. Now, leveraging the technology to improve outcomes, continuous monitoring, retail clinics, connected home, auto patient accessibility, virtual care circles, omni-channel experiences, intelligent treatments. For want of time, I'm not discussing individual components of this leveraging technology. How do you do it? Definitely artificial intelligence, intelligent machines like drones are something going to be in the future. So for better outcome, there are four pillars for these digital initiatives. This is smart care, care anywhere, empowered care, and intelligent health enterprises, something very, very important. Now, this is one move from the government of India, telemedicine practice guidelines launched 25th March 2020. It is part of normal practice. You can use it. It provides practical advice to both the doctors and the guidelines and regulations to make it safe and patient provider. And we know ISRO had launched in 1980s this launch of telemedicine way back in 1980s. Lakshadweep and J&K were covered those days. Andaman Nicobar Islands were covered. The features of telemedicine is important. I'll just touch upon few slides. Doctor can choose the medium of telecommunication, whichever means you want. He has to maintain the same standard. Patient is responsible for the accuracy of the symptom. Caregiver can give the information on behalf of another patient, like a father or mother of a child. So you can use chat, text-based, video consultation, audio consultation, literally everything. This flow chart shows the flow. How do you do? After you take a consent, you decide whether telecommunication or emergency advice is required. If emergency, please stop telecommunication, refer them to a physical consultation. If not, you can go take the proper history, do the management strategies, which can be health education, counseling, specific treatment, and then you can send an e-prescription online itself. And we know during COVID, the physicians can interact with the patients, gather history, analyze their self-monitored SMBG and self-monitored BPs. This is for chronic diseases, and telemedicine has allowed us to consult the physicians away from hospitals, which could lower the chances of COVID infections. I'm sure all of you have experienced this. Just to show you some evidences, RCTs, randomized controlled trials of telemedicine, which has proved beneficial to bring down the A1C. Even a Cochrane review of 21 RCTs of patients with diabetes has shown that about up to 0.31% compared to patients who didn't use the telemedicine has shown the benefits of telemedicine. And telemedicine is here to stay. Look at this Economic Times and Business Standard snippets, which has clearly showed that telemedicine could save India $4 to $5 billion every year. And this is showing again the growth story. It's a firmly here to stay. There is a right time to jump on the bandwagon. Telemedicine expansion is fueled by the massive growth of mobile data consumption, which is going to be about 40% annually for the next 5 years. And that is what is going to be expected. About 1 billion Indians are supposed to have smartphones by 2025. Out of 1.3 billion population, we're going to have this. So by 5G advent, we're definitely going to move forward. And in future, with faster connectivity, more data transfer, it means that the 3D telepresence market, you can literally be present with a 3D picture in patient's house and to take care of patients. This is what we are going to do now. We are doing a virtual 2D video call, but it can be a 3D video call where your image just goes on and you can see the patient virtually, similarly on your side. So the way forward, it is important to focus on following broad issues in this initiative have to be succeeded and scale. Proper training of doctors, educating them, healthcare professionals. A much higher level of public-private partnership is needed. Appropriate IT infrastructure should be in place. Working towards standardized EHR is a must. A national health IT policy needs to be formulated. Efficient management structure to deploy EHR should be in place, and efforts should be made to sensitize healthcare workers related to the importance of the electronic health records. And synergy between software development team and the healthcare delivery system should be there. And organizations like RSSDI API might come forward to have an uniform pan-India database at RSSDI. We're working towards that. Definitely, we have started our initiatives to create a common platform where everybody can use a same telemedicine platform so that we create a lot of pull-in, lot of data across India, at least through the members of our organization. Dr. Bansi Sabu has taken that lead. Train the trainers, mentoring program can be e-based. Go down to district, sub-district places to encourage creating the e-data, being in accordance with the laws of land. Of course, we need to follow the telemedicine guidelines. To conclude, international telemedicine initiatives are bringing the world closer, and distance is no longer a barrier to attain a quality healthcare. Lack of awareness, acceptance of new technology, both by the public and the professionals, are challenging in wider use of this technology. Governments now are starting to take keen interest in developing technology-based practices because they know they can save a lot of cost, and technology can be utilized effectively in management of chronic diseases during pandemics like COVID-19 and even afterwards. So I just foresee in our country, there can be a booth like this, which used to be a telephone booth earlier days, the kind booth, a biosensor equipped health quest where there is a total privacy. You just get inside to this, you wear sensible wearable sensors. I showed you a watch or a stethoscope, virtual stethoscope, all that. And then you can get a consultation by the doctor who's sitting in a remote place, and you can UV disinfect this place after every use. And this is going to be available in airports or in busy places like marketplaces. This is what I see as our future India because of the digital or the IT revolutions what we are having in our country. So let's embrace the digital for brighter future. Thank you very much. And these are my references. Any questions, I'll be very glad to answer. Thank you very much, sir.
So thank you, Dr. Srinivasa, for lucid presentation. And you have covered all the aspects right from collection of the data and the management of data, safety of data, and use of the nano sensors, technologies, and everything you have collected beautifully. And inside that, you have even shown us a bigger market for data mining and data management, which is going to come up. And this big data mining will be a future for medical science to create a better world to live in and have more access to the newer molecule and newer development along with the new technology development to manage the health. So thank you very much for your lucid presentation. And
Thank you, sir.
Gopika, is there any questions we are having? Dr. Srinivasa will be leaving soon. So is there
So
any?
we don't have any questions as of now, but I have a question for you, sir. Sir,
Yeah.
I believe that you have been practicing telemedicine during this COVID time. So what do you think was the number one challenge that you faced while using telemedicine?
I think the common belief of our patients in India that you need to be seen physically. That's the greatest challenge. But I never faced challenge even in an 84-year-old, 85-year-old, the grandchildren with their help, they could do a video call. And that's very, very satisfying and encouraging. But of course, about 10-20% of the patients still believe that physical face-to-face is the key. And the doctor's touch or the magical touch, they still want to continue. And that's the sad part of some patients where they still think the conventional approach is what. And but 80%, I would say very gladly that they have accepted this telemedicine, and especially the video consultation, the very, very comfortable, convenient, and even illiterate patients, like I said, 85, 84-year-old happily consulting me with the grandchildren.
Thank you, sir. Thank you so much.
So
Dr.
I will
Vasan,
hand over to
Dr. Srinivas.
Dr. Aka, you have a question? Yeah, please.
Yes.
Yeah.
Yes, sir.
Dr. Srinivas, we had one paper submitted in EC in telemedicine. Okay. In rural part and in urban part of central India, we had that video consultations. What we got from that patient in this COVID era, although they are coping with you and they are having a good telemedicine approach in their treatment protocols, but they want when we contacted later on, they want a physical visit, and most of the times around 20% of the patients were refusing to pay fees in telemedicine protocols. So this is the challenge. This is the practical challenge. What they see that they think that by doing teleconsultation they need not to pay because the physical touch is missing. And once COVID era is over, how you place this telemedicine in future India? Because COVID is someday it has to go.
Yes, that's a very nice perception by the patients. You clearly alluded, sir. But remember, you should choose an app where only after paying the fees, they should enter for your consultation. Otherwise, they are not entering. So you should avoid your WhatsApp consultations or telephonic consultations or message prescriptions, SMSs. So when you avoid that, give them that common number where after they pay, they have to get into the consultation. So that is something which will definitely negate your apprehension about the payment part. Otherwise, there is no consultation. Number two, after the COVID, when it settles, I'm so impressed and so happy and comfortable that I get more time for these kind of webinars now to read more, to do my own personal activities. I'm planning to continue the second half with digitally only. Only the first half now, both the times I used to go, typically like all of us. But now I'm so impressed from last 6 months that I'm going to make one session telemedicine and one session face-to-face. This is going to be my future.
Yeah, I
Yeah.
fully agree with you, Dr. Srinivasa. And in my experience in last this COVID period, I had a similar, but the patient has to take appointment with my secretary, and my secretary has to collect the fees and other details in advance, and then
Yes.
only consultation is arranged where I can speak to the patient. So in a bigger perspective, it is a process, so the patient has to come through that process. So you record the data, at the same time you write their data on the computer. So I tell patient ki, if you talk to me directly, I will not be able to access your data until you make the payment and your file opens over there. So that makes them comfortable, and they understand that we are seeing their
Yes.
data and then giving opinion rather than just advising as we used to do 10, 20 years
Correct.
ago.
Correct.
Take
I
this,
think
take
that's the
that.
best
So
method. And also the patients don't realize, sir, that the waiting period at a clinic, the travel time, the
yes,
petrol or the time somebody has to accompany to bring a 80-year-old person to the clinic,
yes.
all that, they don't translate that as a benefit.
And
Nobody translates
actually
that.
that only made them to pay quickly because now they
Exactly.
know, otherwise they have to hire a car,
So I
take
think we
the
should
one of
enlighten and
relatives.
Yeah.
Yes,
yes, Dr. Raka.
Because we are novice to this platform. Our paper on an EC was suggesting that the patient interaction is not like that. Patient don't want to pay in second visit because they don't think like it's a physical contact. We are doing, and one more thing in protocol is that whether first consultation regarding consent should be video call or not.
It has to
Because
be video as per the guidelines, telemedicine guidelines, 25th March. There is no doubt. And if somebody cannot do a video, then you have to document why the first consultation was not video. For example, internet issues, you can document. You can say the patient is only comfortable with the voice call, but you need to document the reason. Otherwise, legally, it is wrong on our fault, our side.
and for that, WhatsApp consultation is most conveniently easily available. So, which software you recommend?
No, personally, software, I don't think we should talk about software, sir, but I'll tell you the qualities of software, advantages of a software or a platform. See, when you do a WhatsApp consultation, example, you may do a video call, you may give them a prescription, type and send, whatever the tablets. But remember, tomorrow, if there is a legal implications on you, you need to retain the data for 3 years.
Oh,
3 years, which you will not be able to do on our phone with your WhatsApp or with your SMS. That is where the health platforms come into picture. They save our data. So when you sign the agreement, you should choose a platform which has got a 256 encrypt. Encryptment is something where nobody can read your data. If you type your name, Dr. Raka, that will be split into about 1,000 numbers, not in the letters. It will be converted into numbers and stored in the third party cloud based. So you should look at all these legal implications whenever you sign an agreement with a platform, and that platform should retain your documents up to minimum 3 years. Minimum 3 years. Maximum is good for us, but minimum 3 years. So, and they will collect the fees. For example, 500 rupees, they may collect 50 rupees or a 30 rupees as their fees for a consultation fee. So you will get your 500. They will collect the 30 or 50 rupees from the patient side, and you will get your payment. And the legal implications, it is stored, and you can give a design your prescription as per your or as per our ICMR guidelines only. We have to do it where your name, registration number, contact number, all that should be compulsorily there. That is a standard format. That minimum requirement in that prescription has to be there. It can be e-prescription. There's no need to print. The patients can download. All that advantages comes in a platform. So while choosing a platform, what you should look at is the implications legally, how many they store, where do they store the data, whether it's encrypted data or not. Because as I said, data is going to be a big money part next. It's like a alternative money in future. So that is something you should ensure that nobody should steal your patient data, and that is an ideal platform. And of course, patients can upload data. They can upload their scans, which I use. They can upload everything. They can write handwriting SMBG, and in handwriting they can write a BP pulse. They can click a photo and just upload. Even the photo they can upload from their mobile phones. So that much convenient we should give, so that acceptance become more and more.
thank you so much.
Thank you, sir.
thank you very much. Thank you. So I hand over the mic to Raka. Dr. Raka, now you can take over and
Yeah.
invite the next part.
Gopika, please share the next speaker slide.
Ankit, can you share the next intro slide?
Our next speaker is Julia. She is ready. Yeah.
Yes.
It's my pleasure to be part of this DiaCare conference. And I am thankful to Dr. Sabu sir and team and the big vision of Dr. Sabu by involving every part of world in this conference. And here is Julia Madder from Austria, Associate Professor of Medicine, Division of Endocrinology and Diabetology. Julia Madder is currently Associate Professor at Medicine in Division of Endocrinology. She received her medical degree at Medical University of Graz, and she also trained in internal medicine and endocrinology. From 2016 to 17, she was visiting professor at the Department of Diabetes. She leads the Diabetes Technology Research Unit at Medical University of Graz. Professor Madder research is focused on diabetes technology, emphasis on insulin pump, CGMS, artificial pancreas, decision support systems. She has published over 90 peer-reviewed scientific papers and served as an associate editor for the trials. She has received several national and international awards. Professor Madder is member of European Association of the Study of Diabetes in Austrian Society for Internal Medicine. She is management board member for Austrian Diabetes Society, within which she heads the Diabetes Education Committee. So with this all accolades, Professor Madder is here to share her wisdom on this part, because she's doing a lot in diabetes and technology. So over to you, Julia. Please share your screen.
Sorry, it did just some technical issues. Shortly, it will hopefully open.
Can you click on the share screen button, the green button?
Yes, it works, but it doesn't open.
Yeah.
It doesn't open the files. Ah, yeah, here it is now. Sorry.
Yeah.
So sorry for the short technical issues that we had. So thank you very much for having me for your huge conference. I'm very impressed about the agenda and the audience. And I'd like to talk to you now about SMBG and remote monitoring. So we already had a very good introduction into telemedicine and what can be done by telemedicine. And now I just want to focus on the smaller part of self-monitoring of blood glucose in that field.
Ma'am, we are unable to see your slides. Can you share the slides? We are seeing your inbox.
Ah, okay, so it did not show the slides even if I'm now...
No. Can you try again?
I'll just close this one.
Yeah, you close this one.
Can you see it now?
Not really. No.
No, not yet.
No, ma'am.
Not now, neither.
No, neither.
Yeah.
Do we have a backup slide for ma'am?
Yes, I sent it to Dr. Sabu via WeTransfer.
Yeah. Ankit?
Ah, maybe now it works. Just one more.
Yeah,
more
working.
try.
Yeah.
Okay,
Sure.
working.
Now I can see it?
Visible. It's visible.
Yes,
Yeah,
yes.
it's visible.
Okay, wow, sorry so much.
No,
So okay, here's my conflicts of interest. And yeah, as all of us are aware, the challenges in diabetes management are present every day, and this is present in all of the year, may it be health, may it be vacation, may it be living under conditions of pandemia. So diabetes management is challenging all of the time. And it's sometimes like walking on a tightrope where you have to, on the one hand side, avoid hyperglycemia, and on the other hand side, avoid hypoglycemia. So here I want to share two very important figures that I sometimes also want to discuss with my students and with my patients, because that helps them maybe to get some empowerment, and it's maybe not so easy to discuss in such a setting. So I just want to show you what these figures mean to us. Usually we have about 2 hours with the patient where we can discuss issues and help him to better understand his diabetes and maybe better understand treatment decisions. But nearly 9,000 hours a year, the patient has to treat his diabetes without our help. So we have to give him kind of a kit to enable him to manage his diabetes alone the best possible way all over the year. And of course, some of the hassles that we do have, especially in people who do self-monitoring of blood glucose without a sensor, we just can see the dots where the measurement is performed, but we have missed areas, especially harmful in the low areas, but of course also interesting to see how, for example, postprandial glucose values would evolve. Additionally, once a patient either comes into our clinic or he shares data with you, data entries sometimes are difficult to read and difficult to interpret, especially in self-monitoring of blood glucose. And I think you in India are even more advanced than we are in Austria, because we do not have such good regulations for telemedicine. So lots of our nurses take the calls via telephone, and then patients just tell them some numbers and they have to figure out how to really use or make use of SMBG. And in that sense, of course, digital data collection could be of great importance, and just one part of it would be the self-monitored of blood glucose, but of course we could also integrate health data from devices that collect heart rate and collect activity, or we could collect data from connected pens, where we have then the insulin dose together with the blood glucose value, or even track the blood pressure of the patients. And once we have such a connected platform, of course, it's a holistic system where we can easier understand and easier interpret patient data. And COVID in that sense even helped us here in Austria, because a lot of the patient visits were transferred into virtual visits, both for patients using SMBG, but also for patients, of course, using continuous glucose monitors. And connected device data can then be shared with the physician, and we have currently various platforms that we allow in our clinic, where we get the transferred SMBG data and can then discuss in a video call the data with the patient. And there are several software solutions, and it's really good to have good software, as we heard before, just for storing the data, but also to help us to interpret where are the problem areas, because then we get the green code or the red code or the orange code if glucose values at a certain time frame are too high or are too low. And of course, some of the tools which were developed even by patients and then sold to bigger companies have challenges around them and kind of motivate the patients to measure their blood glucose frequently enough, and also motivate patients to achieve target values as recommended. And on the other hand side, such platforms have the potential to transfer the data then to us at the clinics. And why could also be telemedicine and remote monitoring in SMBG be useful? As we heard before, there are remote areas. And of course, in all of our countries, the experts are not available at every site. Patients do not need to commute, and you can interact more frequently. There are special populations who could benefit a lot, especially children, for example, pregnant women, or also people who need support like elderly persons. It gives you flexibility, because people who need to work do not need to take the commute on the one hand side, or if you, for example, go to study in another city, you do still have the chance to communicate your blood glucose values to your treating physician at your city of origin, and you can keep care in that sense. And of course, the pandemia made us aware of kind of the risk of infection when patients have to wait in a waiting room together with other people, when they are on the commute to the clinic. And of course, also patients are afraid of visiting hospitals and clinics at the moment because they fear that they might get infected here. So what we saw not only in our department, but also in the emergency room, that patient visit in physical, they reduced because people just simply did not approach us. So it was completely different to Italy, where they had kind of overcrowded emergency rooms. In our emergency room, visits extremely dropped. But on the other hand side, we had a lot of acute admissions then from patients who were with their glucose way out of control and had ketoacidosis and had high blood glucose values, or even suffered from a very bad diabetic foot syndrome infections, who had then to be amputated. So it is really, really important to kind of have the chance to take good care of our patients even in these difficult times. And just to shortly mention type 2 diabetes and COVID. So there is a large proportion of patients who have diabetes who then suffer from coronavirus disease. And this is why it is important to take good care of our patients also in that situation, because what we saw, people who have both type 1 and type 2 diabetes and are out of control. So we have good glycemic control for the both groups to the left. So we have type 1 in the light blue and type 2 diabetes in dark blue. And to the left, we have good HbA1c, and to the right, we have not so well controlled diabetes with HbA1c above 10%. And we do see increased mortality in the ones with uncontrolled diabetes. And what we also see when it comes to urgent admission to the hospital, people who arrive in the hospital without previous good glycemic control, they suffer higher mortality and they are diagnosed with COVID-19. And so how can we use telemedicine in self-monitoring of blood glucose? There was a study performed by German colleagues in 900 people with type 2 diabetes taking insulin, and they were seen in 101 practices all over the country, and they were seen over 12-month period, and they had intervention versus standard care, and they assessed glycemic control, patient-reported outcomes over that study period. And I just shortly want to show you that system. So they had this integrated personalized diabetes management, where they had the structured documentation, structured and systematic analysis of the SMBG data, personalized then the therapy to the patient, assessed the efficacy over time, also had diabetes educators who structured education, and then adjusted the therapy to optimize the glycemic control. And that was kind of a continuous cycle that ran throughout that year, where that cycle was reassessed with every iteration. And then the glucose control after 12 months was compared. And one saw that the blood glucose and change in HbA1c at 12 months was significantly better in the ones seen with telemedical support, even when just using self-monitoring of blood glucose. And that drop was already seen at 3 months and then continued to stay until the end of the study. And another study investigated this for 24 weeks. So that was just a shorter study. And they had SMBG alone with regular in-clinic visits, which is usually every 3 months. And the other group, they had SMBG plus an app with even a text messaging service that was personalized to the patient. And it included both people with type 1 and type 2 diabetes. And it was the meter glucose that was assessed. So it was also not continuous glucose monitoring. And also in this group, one saw a drop in HbA1c over time, and that was more pronounced in the ones in gray, which were the ones using the meter and the app, versus the ones who just used the meter alone. And then, of course, it's also important to understand how people feel when they're treated with self-management support when doing SMBG and having telemedical support. And they interviewed people with type 2 diabetes aged over 50 years. And they wanted to know about the potentials of telemedical care when using SMBG, but also, on the other hand, side about concerns. And the people had mixed feelings. So they saw the potential of an increased involvement, better empowerment, and also felt secure. But they also felt a bit ambivalent and uncertain with the lack of personal contact. And if I just want to read out one of the sentences, which was, of course, kind of prevalent in people. It's too difficult to use for me. I can't even type on the smartphone. So that was especially from the elderly ones. But as we heard before, of course, they could have kind of the support maybe from the family together with the patient and then do such a visit together. So that might be an opportunity to overcome such issues. So what could be the benefits of such digital healthcare support in SMBG? We have more comprehensive data, we have structured analysis, and then can do better decision making. We can support the patient when he or she is in need. It empowers the patient when they use the technology also to self-analyze their glucose patterns. It can be done remotely, which is helpful for the working population, for the elderly, for people who are in school, or for people who live in rural areas. There can be data transfer to other clinics. For example, when the patient is relocating, or the patient can still stick with his initially treating physician when he's relocating to another city within the country if he feels more comfortable. Or you can consult another specialist if you share data and get their insight and their views on your treatment ideas. Of course, there is open questions left, which is, for example, how often should we see the patients within telemedical care? How often can we have in-clinic visits versus remote visits? Inert patients are, of course, difficult to treat anyways. What is the amount of data that is needed? Reimbursement is still not covered yet. Data security is sometimes still a concern. Then there are legal requirements. What are allowed platforms? What does the hospital IT allow you to use? And acceptance rates by patients might depend on age and education levels. And of course, the devices should be interoperable if there should be automated data transfer. Yeah, with that, I'm at the end of my presentation and would like to take questions if there are any.
Julia, for fantastic talk. I am Dr. Bansi Sabu, organizing chairman.
Thank you.
Yes, it was real great.
Thank you, Julia, for addressing emotional aspect of teleconsultation also. That mixed picture, that was a very true kind of perception from patients, that some patients are happy, some are not happy. How you translate these kind of applications in rural part of world? You people are just handling most of the insured patient. These patients are having all kind of facility. What are the challenges for rural world?
Yeah, so I think that there might be differences, of course, between India and Austria, because our rural population still is kind of covered by healthcare and everything. It's just that they do not have the physician available at their sites. So for them, it's mainly the distance that they have to cover, or they are seen by their GP, who may or may not have any idea about treatment of diabetes. But of course, for people who do not have the money and who do not have insurance who covers it, it's still difficult. Fortunately, we have some clinics also here in Austria who cover for patients who are not insured. So there is still a small proportion of illegal migrants who are not covered by insurance. So they can be seen in such a setting. But that's, of course, the most tricky part. And for them, I guess it's also the difficulty in even getting the devices for glucose monitoring, or even knowing that they suffer from diabetes. So that's still a big issue in the patient inertia or person's inertia to even recognize the condition.
So we have one.
Yeah.
So we have one question from the audience, from Dr. Abhishek Kumar. Do results get automated transferred to the app from the glucometer, or is it manually fed by the patients?
So some of the apps are having it automatically, and I think this is a great advantage because then you do not have transcription errors. We also used such a system in the hospital, and we saw even well-trained nurses sometimes have issues with the digits, so that they, for example, put a 1 instead of a 2, and then you have like a hyperglycemic value, which is in fact normoglycemic. So the automated transfer of data is way much better if possible, and a lot of devices are already connected. So if you choose to go for telemedicine, then you should also go for a connectable device.
Thank you.
Julia, in your setups, how many patients you subject for CGMs in routine type 2 diabetic patients?
So Abbott made a very smart move in Austria, because they declared with the insurance company, and we have like a very large insurance company which covers like 90% of people. So that's the Austrian insurance company, so as it is called. And so with them, they negotiated that everyone who is on basal bolus insulin therapy gets intermittently scanned glucose monitoring. And so I would guess about 40% of the people with type 2 diabetes on insulin, so not everyone, but on insulin, would be covered. So the chance get it. And Austria is still a premixed insulin country, and also those patients unfortunately do not get the continuous glucose monitor, but the ones who are on basal bolus receive it.
Dr. Matter, we have one more question for you from Dr. Sanjay. Any glucometer which connects sugar level to any digital software?
Sorry?
Any glucometer which connects sugar level to any digital software? Do you have any glucometer which connects with the software? So that's a question. Probably mySugar app connecting with the Roche glucometer.
There are several Roche devices, of course, that are connected. And it's a tricky question, because in the future it might be even more appropriate by Roche, as they kind of bought mySugar app. But there are several diaries as apps who are kind of open for various glucose meters. And the most important thing is that they do have the Bluetooth or near field communication available. Then there are some who can read the digits from the screen. So when you take a photo and then transfer the data in, so that's also a possibility that was also looked up by the mySugar company. And most of the meters even now have their own software. So that could be also used in the ones who have like Bluetooth available.
Julia, you are doing so much research in all CGMS and data monitoring of these glucometers. Can you suggest a smart use of glucometer when the patient is not subjected to CGMS, when the patient is not subjected to frequent clinical visit? Can we design a smart way of using SMBG? Can we counsel our patients to smart use of SMBG so that it can be incorporated maximum amount of time in range? We can decipher the time in range concept with SMBG.
So I think, for example, the ones who take more frequent insulin injections should measure whenever they inject the insulin. So that's what we currently recommend them. And the ones who are on basal insulin only, we recommend them to take 1 glucose value in the morning every day and do a profile once in a week. And then we ask to kind of move the days across the week so that we do not always get the Mondays, which might be the worst or the best day in the week, but we kind of move along the week. And in people who adhere to that advice, I think we get good patterns out of it. And we have a lot of insight. But of course, there are people who do not want to show us the data. So even if they have a CGM monitor, then they say, oh, I forgot it in the car. Sorry, I'm just here without my meter. I'm here without my data. Then you say, okay, sorry, it's difficult. We cannot really discuss anything today. But yeah.
Thank you so much. Dr. Suresh, you want to say something?
Yeah, thank you very much for the lucid presentation. And we got insight into what is happening in Austria and what we are doing here. So thank you very much for your kind contribution. So we can invite the next speaker now.
Thank you. Bye.
Thank you. Thank you so much.
Thank you.
So our next speaker is Dr. Anjali Bhatt. Dr. Anjali Bhatt is a well-known consultant endocrinologist from the Pune city, and she has contributed to medical science in enormous ways in various institutions and everywhere. So I invite Dr. Anjali Bhatt to start her presentation. Anjali Bhatt.
Thank you, sir. Thank you, chairpersons, and thank you, Bansi Sabu, sir, for having me here today. I'll share my screen. Is it visible?
Yes. Yes, ma'am.
Okay, thank you. So the topic for me today is potential of real-time continuous glucose monitor in helping to enhance glucose control in diabetes in India. The talk is not funded by any company which provides continuous glucose monitors or real-time continuous glucose monitors. So that's the disclaimer. To start with, I have tried to identify certain keywords from this topic. And those keywords go as potential, a real time, though continuous glucose monitoring is another part of this keyword, but what is going to be key in this particular talk is going to be real time. Third is enhancing the glucose control, because day by day with information available from the evidence, we are enhancing our understanding about what does it mean by a good glucose control. And particularly in this country, where there is a very huge burden of disease. We have more than millions and millions of patients with diabetes, large proportion of uncontrolled patients. I think this is a problem in most of the countries, but overall we have patients which would average out to 9% of HbA1c. So we have a large proportion of uncontrolled patients in spite of the advancement in the medication. There is something that we lack in the understanding of the physiology, and what we are lacking is the ability to change the behavioral patterns of the patient. We have extremely busy OPDs, so there is hardly any time for the doctor to understand the issue from the patient and explain what needs to do to the patient. And a fact that can be used as an advantage or a disadvantage, out-of-pocket payment, which also gives a freedom of choice to our patients to choose a particular technology and give priority to spend their money on this particular technology than any other thing. So out-of-pocket payment, rather than taking it as a disadvantage, I would like to take it as a freedom of choice of choosing a technology over other expenditures to improve their health. What has the recent times taught us is two things. One, we have become much smarter and accepting to the technology. I don't think we will be meeting digitally in Bansi Sabu sir's conference ever again or ever in the past. So COVID-19 times have definitely taught us to be more technology friendly and accepting the technology. And secondly, a big lesson that these times have taught us is giving the priority to health can be much better than giving the expenditure to the illness. So some technology which will probably improve the health will always be a good investment rather than spending that money on illnesses. So let us come to first keyword, that is potential. Now this is a title side of my talk in the same conference in 2019, that is last year, which was a debate over should HbA1c still be the target for the diabetes treatment, main target. And the audience at the end agreed that yes, HbA1c should still be the main target for treatment of diabetes in our patients. But what this year has done is it has created a potential for accepting the technology. And another thing has happened is that because of huge increase in the requirement or the need, the technology cost has tremendously came down. So we have a recent introduction of a continuous glucose monitor and their real-time version by Abbott, which is reasonably acceptable from the cost point of view. So definitely this has created a huge potential for such devices in helping our patients to reach their target. Coming to the second keyword, that is real time. When it comes to understanding what is time, I don't think anybody would be better than Stephen Hawking. And what he said about real time is the universe has a beginning in the real time and an end at a singularities that form a boundary to space time and at which the laws of science break down. I would like to take up this last words, laws of science breakdown. I'm sure, in spite of doing all the best possible management of a patient, there would be times when the laws of these science will fail. The patient will have a low blood sugar. The patient will have a high blood sugar. There would be some foods which will change according to the time, culture, and the year, the time of the year. There would be times when the patient would be able to exercise, who would not be able to exercise. All the laws that are recommended are bound to fail at a real time, and that real time will come in the lifetime of the patient at some point or the other. At that time, if we have a tool which can suggest what is happening at that particular real time, and we empower ourselves and the patients to intervene at that particular real time, it's definitely going to enhance the glucose control. Now I'm going to come to the third keyword of the topic, and that is enhancing the glycemic control. Now we have come a long way of understanding what does glycemic control mean from the beginning, where we thought that we need to control the blood glucose at fasting and post-meal stages. Then DCCT taught us the importance of glucometers, where we can use these laboratory parameters. We took it to self-monitoring of blood glucose, on which we had a wonderful talk by the previous speaker. Then came HbA1c, which told us that not only a point of care blood glucose, but an average glucose over few months should be targeted to improve the outcomes, long-term outcomes of diabetes. Now we have two more steps ahead of it, which tell us that even within the normal HbA1c, we need to make sure that there is no glycemic variability. That means the blood glucose is not very low or very high, and very importantly, quality of life. What quality of life issues that come up with multiple SMBGs is the finger pricks and painful finger pricks that a patient needs to do. If a patient is on multi-dose injections every day for 4 times in a day, and he needs to prick himself in for 4 times in a day before taking the injection, I am sure all our doctors can correlate to this pain that our patients has to undergo. And that is why this monitoring has actually made a transformation and a game changer shift in understanding and reacting the way we do. I actually like to call monitoring as one of the anti-diabetes treatment, which does not need a CVOT and can be as useful as another drug required or needed for management of HbA1c. Now, what we have learned from CGMS is to improve the glycemic to understanding of glycemic control, where time in range was the concept that was introduced from use of continuous glucose monitor. And what it showed that in spite of normal HbA1c, if time in range increases by 10%, the complications reduce by a huge extent. And this is a recent evidence which came from the pooled data of DCCT. So this is a data which was long time awaited and which has come to us, which correlates the continuous glucose monitoring data relating to the long-term complications, because that is where we relied on HbA1c, because that was the only parameter which showed us that a parameter which was correlated with the long-term complications of diabetes. Now we have an evidence that higher the number of times that a person has his blood glucose in the range, the lesser the chances that this person will develop chronic complications. And even though this data was based on glucometer readings, obviously in a logical way, the continuous glucose monitors might increase the chances that a person remains in the range. And what we now expect, apart from being apart from HbA1c being under the target, we also want a patient to have around 70% of his readings within the required range. Now, this range can be different for different people. We generally take it as 70 to 180 milligram per deciliter, but we want our patients to have 70% of these readings between 70 to 180. Less than 5% in low range, less than 1% in very low range, and 10 to 20% readings may remain on more than 180 range is what is currently recommended. And what is data is a continuous glucose monitor. We are just talking about a continuous glucose monitor, which will give us an ambulatory glucose profile that is shown on the screen. So what does it mean is that if you can see on your left panel, the time in target is given directly on the screen of a continuous glucose monitor, where the patient is shown to have 54% reading in target, 12% below, and 34% higher. Now, this is the direct information about time in range. What DCCT has done is it has taken all the glucose values that are done by SMBG and then plotted that in a sheet or whatever calculator they use, and then calculated how much time were in the normal. That can be very well done with a notebook in which the patient has written the values. But what CGM can give us is not only giving the minute-to-minute reading, but also providing a graph, what we call as ambulatory glucose profile or AGP, which can give us day-to-day level graph or cumulative graph of last 7 days, cumulative graph of last 14 days, and the average out of the blood glucose at a given particular time of the day. And what you can see on the screen is it clearly tells us on every day how many times the patient was in the target, below the target, and above the target. So this is one part of real-time continuous glucose monitoring that we are, the patient and we are given an ambulatory glucose profile. We directly know how many times the patient had been in the range, that is TIR. Now coming to the real-time part of the continuous glucose monitor, what real-time glucose monitors do is that in the professional continuous glucose monitors, patient wears the sensor, but the patient cannot see the reading. The patient has to come to the healthcare professional to read the sensor. There are advantages of such types of professional continuous glucose monitors, but because we're talking about real-time glucose monitors today, what we will be looking for is a current glucose reading. The patient has a transmitter or a reader with him, which looks like a mobile, and the patient will have a small sensor on his arm or abdomen, or depending on the manufacturer, and the patient just swipes his phone over the sensor and gets the reading as it is shown in the graph. Now, it not only gives you a current glucose reading, it also gives you a history of last 8 hours, which makes the patient mandatory to scan the monitor at least once in 8 hours. Otherwise, the previous graph will be refreshed and you can see only the next period's graph. And what most important thing these glucose monitors do is to give you a trend. Now, what does trend means? A trend arrow, as you can see in the graph, there is a glucometer value of 112, and there is a slightly slanting arrow going upwards besides it. So these arrows give us trends. A sleeping arrow means the glucose is remaining stable. Slightly slanting upward arrow means glucose is going up, but slowly. And a perpendicular arrow going up tells you that the glucose is going up very fast. Similar information can be taken about the glucose going down, slowly down or slowly, very fast down. Now we need to empower ourselves to use this information. And what we are going to do to enhance the diabetes control in our patients. So there are 3 points that we would be highlighting. One is, we have seen how monitoring is the biggest game changer, and I would like to call it as a diabetes therapy which does not need CVOT. We have seen what is the usefulness of such a monitoring in our patients. Very important when it comes to this particular talk is, what are the options that are available in our country and how much they cost, and how are we going to put them in the management of our patients. And then there are simple case-based examples as to how we are going to use and interpret real-time continuous glucose monitors, making it to the maximum use and not letting it be a headache, because the technology can be sometimes misused and can cause irritation. So let's see this slide again from my last year's talk, which showed what are the CGMs available in India in 2019, where real-time glucometers were really high, high cost and affordable. We had only Medtronic and Dexcom's sensors available, and its reader cost some more than 50,000 rupees. Now we have 3 real-time continuous glucose monitors, which somewhere around 52 and sensors around 2,500 to 10,000 rupees. We have a which costs 6,000 rupees, and a personalized reader which can cost 6,000 rupees. So these are real-time continuous glucose monitors that are available in India on today's date. So these are the informations, and depending on patient's choice and particular need of you and your patients, one of these can be used. Now, as I said, that unless we know exactly which technology is a nuclear bomb for something that can cause destruction rather than usefulness. So similarly, we must identify our patients so that such advice can be used. This is not for everyone. As a replacement of laboratory or glucose trial that showed us that there is a correlation between TIR and chronic complications of diabetes. The correlation association, the co-relator of association was around 0.7 to 0.8. That means that 70% of your patients, HbA1c and the glucometer readings or the blood glucose reading will match. There is around 20 to 30% of our diabetic population where more evaluation will be required in addition to glucometer readings and the HbA1c. So mind well to choose a right patient for right technology, and I'm sure you are unlikely to fail in that. It can sometimes cause anxiety and stress because can give irritating alarms, and the patient as well as doctor is not empowered to react on the alarm. We are not made sure that we as well as the patient is empowered to know which alarm is to be intervened and which may not be intervened and can be left alone. So it's very important that we ourselves are empowered to use it, and we spend enough time with the patient to teach them how we are going to respond to the continuous flow of information that is coming to you about yourself. So it can be really scary and stressful sometimes. So there are 2 very important indications that I find in the clinical practice about. One are the patients who need real-time intervention, a minute-to-minute intervention on the value that is provided. And second, a very important use of real-time continuous glucose monitor, or for that matter, any continuous glucose monitor, is going to improve our metabolic understanding, leading to behavioral change. Now, this is something which I would like to call as investment in understanding your metabolism. The first group of patients are young type 1 diabetes or any other type of diabetes which are on multiple dose insulin or insulin pump, in which we need to do real-time management of changes in the glucose. Right now, my glucose is pre-meal glucose is 100. I need to calculate my carb. I need to understand the insulin sensitivity factor. I need to calculate the dose of insulin that I need to take. And I'm using this continuous glucose monitor. I don't want to take 4 pricks per day. This is the classic and life-saving example of a person badly needing a real-time continuous glucose monitor. What it is also going to add is prediction of hypoglycemia and followed by a right or appropriate intervention. For example, if right now a type 1 patient's glucose is shown to be 70 and the arrow is going either slowly down or sharply down, the patient absolutely needs to stop doing whatever he or she is doing and intervene by taking glucose. So this is another thing that requires a real-time continuous glucose monitor and prediction of hyperglycemia followed by intervention. Something like glucose of 400, blood glucose going up very sharply, the patient needs to increase either the basal rate of the pump or take additional short-acting insulin to control the hyperglycemia, preventing the patient going in ketoacidosis. Now, this is the classic and life-saving example of use of real-time continuous glucose monitor. What these monitors can also do and what can be invested in a real-time continuous glucose monitors by few of our patients, which can be anyone with any type of diabetes, with any type of treatment that is going on. Now, this is a graph of continuous glucose monitor, may not be a real-time continuous glucose monitor, which can give you glucose profile over past 7 to 14 days. Any CGM can do. We can calculate what is the timing range, how much is the glycemic variability, when is the particular time of the day that the glucose is going or down, what are the behavioral changes which are associated with it, and understanding the individual patterns of day-to-day glucose levels and identifying underlying behavioral or iatrogenic factors, where we might need to tell the patient to do dietary changes or we can do medication changes. What real-time glucometer adds, continuous glucose monitor adds, is a real-time enforcement of advice regarding foods to be avoided, but the advice is not taken seriously. I have so many patients to whom I tell that the bakery products are not good for you, but when this gets reinforced, when they eat 2 Marie biscuits and see that their blood glucose is going to 400. Now, these are the types of behavioral changes that are great investments in patients who can take that advices more seriously if they are shown in the real time that this is what is actually happening, rather than we expecting them to believe us blindly. Now, this is something which is understanding of the metabolism. For us also, it is going to be useful to understand patient's diabetes better. And for patient also, it is going to be useful to understand what suits his metabolism better and what doesn't. Coming to a few of the last slides, when you use a real-time glucometer in the practice, it's very important to understand and give time. One, to know the device, use the device on yourself and see what are the functions, what are the arrows, what are the alarms, what needs to be intervened on, what may not be intervened. Of the patient's empowerment to use and understand the technology. Maybe it is nothing to do with the patient's literacy. There are patients who are educated but don't want to accept the technology, and there are patients who will somehow use the technology in spite of we feeling that they might not be able to get. So understand the empowerment of your patient and empower them to accept and use the technology of the patient's need and how the device can be useful for the particular need. From my side, I have tried to give you 2 scenarios where patient needs RT-CGM and we can utilize, and you can have a number of more indications for such needs. Of need or no need for real-time interventions. You might have a patient who can keep calling you if the blood sugar is 201 because you told him that the blood sugar should be below 200. So these things need to be explained very well, that these are the things that need to be intervened. These are the things it may be left alone. We need TIR in 70% of the times. It doesn't have to be 100% of the time. So that is something that needs to be going as a clear message. And cost effectivity of this financial investment. Like, will investing in an RT-CGM will be more useful rather than spending on a ketoacidosis hospitalization, hypoglycemia hospitalization, or investing in understanding your metabolism so that you can prevent the long-term complications of diabetes. With that, I'm coming to the summary slide. We have seen that it is not the technology, it is we who are going to use the technology in certain way that is going to decide a potential of a technology to be useful. We know that we need to move at least 2-3 steps ahead of fasting PPNH, where there would be certain number of patients who would require TIR to be considered to prevent life-threatening hypoglycemia, ketoacidosis, and to understand the glycemic variability and metabolic parameters. We've seen what are the options available for us when we want to use a real-time glucometer, continuous glucose monitor in our patients. And definitely the potential use of such real-time glucose monitors are increasing. One, because we are becoming more and more technology friendly, and the technology is definitely coming down in cost and coming into the reasonably accepted cost bracket is what I feel. With that, I would like to thank the chairpersons again and Bansi Sabu sir for giving me this opportunity. I would be happy if there is any discussion over this topic.
Yeah, thank you, Dr. Anjali, for your lucid presentation. And we got present to so many new updates on the technology and the continuous glucose monitor and sensor available, including their cost. And the glycemic control of the Indian population is going to improve in coming years. I can see that a lot of technology use is happening in our country. And thanks to Bansi Sabu for creating this regular and having a lot of interest in creating the better glycemic index for the Indian population and worldwide. So your topic was very interesting and it was self-explanatory. So I don't have any more question. Dr. Raka, do you have any question? Please.
So kindly
Dr. Raka, you are
I think you need to unmute yourself, sir.
Sorry. Your talk is always on, Dr. Anjali. You have given wisdom of time in range, and it's always very easy with the
Sir, kindly unmute, sir. I think it got muted again.
Yeah, it's very easy with CGMS to talk about time in range to the patient, and we all should practice like that. We have to decipher them the importance of time in range, because with CGMS and with real-time CGMS, it has done a lot to the patients. And your presentation has shown all the aspects of that: the use of technology, the good use of technology, the real use of technology. I thank you for your presentations. I have no more questions for you.
Ma'am, one question. So after a long wait, Libre has been launched in India in November. So what is your experience using the new Libre?
Right. So as I said, Gopika, this is not new to us. Real-time continuous glucose monitoring was there with us by Medtronic for a long time. We have also had our experiences on Dexcom. But the biggest advantage with Abbott's Libre is the cost coming down. Right. So 6,000 for a reader is something that many of my patients would like to invest in with the kind of benefit that it has. So first thing is cost about it. Second thing is it's a glucometer. So when you're not using a sensor, you can use that device as a glucometer and as a ketone meter. That is another advantage. It becomes easier to tell the patient that if that time you can use this monitor as a glucometer. So these are the two advantages that I see with Libre, which will be over and above the previous, because the arrows, the trends
all that, the graphs, the AGPs, all that were available earlier also with either Libre's continuous glucose monitor, Libre Pro, or with Medtronic and Dexcom. So these are, I think cost would be the best thing to put in.
Yeah, when compared to the Guardian Connect and the Dexcom, which was which are still available, Libre has revolutionized the way we treat diabetes. Probably for the type 1s who are finding cost as the biggest barrier and as the greatest challenge. But in our center, we were facing issues with the sensor in the initial times because for many of the patients, it would stop in between, though it should work for 14 days. In between, it used to stop, and some of the patients who had near normal HbA1c, near normal glycemic control, then the sensor used to show low glucose trends. And initially, we thought it has a non-adjunct to glucose meter, but then we started telling our patients to check with the glucose meter because many of the values were not so accurate. But now I think it is slowly picking up.
Yeah, now see these sensors are pretty accurate. There would be definitely challenges in using it, especially the storage which needs refrigerator. That is one challenge that happens if the electricity goes and the storage is not proper, then the sensor might not work properly. The application, the patient's use of the sensor. Because
being a consumer product,
so that if we come over those glitches, I think the efficacy of these glucose meters is pretty good. I mean, even during the hypoglycemia and the hyperglycemia.
Yeah, much better when compared to Libre Pro. But we were expecting much more accuracy. When looking at the MARD, we were expecting much more accuracy, but that was initially lacking. So that slightly disappointed.
The technology also has its own intelligence. That the technology has its own intelligence, which we like to call artificial intelligence. So it makes itself better. So more we use it, we get better in using it, and the technology gets better itself. So we shouldn't wait for it to become the best. Rather than we should
go on using it.
Yeah, improve ourselves and them, because there's no way we can go back. We cannot go back to the past without technology. We have to go forward.
Rightly said. Thank you, ma'am. Thank you so much for that wonderful session.
One drawback, Dr. Anjali, with this Libre, that we can't connect 2 or more patients with same reader at a time.
It is not supposed to be done like that, no, sir.
It's a patient product.
Yeah, it's a one-to-one patient product. If it has been done to so many, then it can be very good family type of reader. Because but anytime you can
the AGP would become difficult to make a AGP. Because at a time for 14 days, unless you have only one patient's data added, then only you can make an AGP.
But we were doing it with Libre Pro earlier. We were doing with same sense. Yeah.
Right.
Yeah,
so Libre being a personal CGM, it is intended for a single
patient. It might come, or some DIY people might find out how to do it.
So I will enlighten on this, Dr. Akka. I use around 2,000 sensor every year. So, and in clinic, same time, 5, 6, 10 patients with different sensor. So you can read any number of sensor. There is nothing wrong about it, because before reading the next, you have to delete the old data. So it is at a time you can read only one, and this sensor data is stored even up to years. So patient can bring after 6 months also, you can read the data again. So it is very safe, and there should not be any problem by mixing here, there. You can do it. It can read only one at a time, and you have to delete the old data, which deleted, and then you read.
I think sir is speaking
full for 14 days only for one read any other sensor at a time in those 14 days.
No, you can read. The reader is common for everything. You know, you can.
No, Dr. Suresh, you are not correct, because we are talking about newer one. Newer one can't be connected. It's one-to-one.
Yeah, we are
for newer one, maybe one, but the app can be downloaded, and I think for newer one you are talking is it, but I'm talking about the older one, which is very easy for reading any number of the sensors.
But you never know. We have a lot of intelligent, techno-savvy people. They will come up with something.
Yes.
It's just a matter of application to the software. That's it.
Yeah.
Thank you so much.
Thank you so much.
Thank you.
So can we move
So
forward to the next?
over to Dr.
Yeah.
Raka. You can invite the next speaker.
Gopika, please share the screen.
Yeah.
Intro slide. Yeah, here comes our learned speaker, Dr. Pratap Jetwani. He doesn't need any introduction. He is an executive member, All India RSSDI 2020-22, Honorable Secretary, Gujarat State Chapter of RSSDI, Organizing Secretary, RSSDI 2018 at Ahmedabad, past tutor for postgraduate diploma in diabetes course for Leicester University Fellow, RSSDI, and Fellow Diabetes India. He is a section editor, Sadicote's International Textbook of Diabetes. He's a member of so many organizations, immediate past president of Association of Physicians of Rajkot, consultant diabetes specialist at Jetwani Hospital, Rajkot, and visiting diabetes specialist at Rotary Midtown Diabetic Clinic, Rajkot. He has presented a lot of papers and in various state and international conferences, ex-editor of Madhu Monthly Gujarati magazine for diabetes patients. And Dr. Pratap Jetwani doesn't need any introduction. He's a very, very good speaker. And it's over to you, sir, for your deliberations.
Thank you, Dr. Raka and Dr. Suresh Purohit for kind introduction, and also Gopika. Let me start by thanking Dr. Bansi Sabu, my mentor, my guide, my friend, for making me part of this prestigious event. Just a minute, I think my screen is there visible.
Yes, sir. Yes, it is visible, sir. Can you go full screen, sir?
Yeah, just I am trying to do that. So thank you, Dr. Bansi and the team, for inviting me to speak on this topic, that is diabetes management in the age of COVID-19 with point of care testing. So today I will be talking about POC testing in the times of COVID-19. How can we help our diabetic patients with the help of this testing? So let me begin by first defining what is POCT. As per the College of American Pathologists, POCT, that is point of care testing, is defined as tests which are designed to be used at or near the site where the patient is located, that do not require permanent dedicated space, and that are performed outside the physical facilities of the clinical laboratories. So very small handy instruments can be used that can be carried anywhere, and where cartridges are generally available, and you have to put a drop of blood inside that cartridge, and then the machine will read the value for that test, be it HbA1c or lipids or albumin creatinine ratio or CRP, or variety of tests they are available. Currently, a lot of tests they are done with the help of point of care testing instruments, starting from bilirubin to reproductive profiles. And nowadays, currently, if we go in COVID-19 diagnosis, then rapid antigen test, even antibody tests, all this, they are point of care instruments are available, strips available, and other things available. Apart from laboratory tests, thermometer, pulse oximeter, handheld Dopplers, even portable sonography machines, they also come under the purview of point of care instruments, because they can be utilized in a bedside manner for the diagnosis of a condition. So if we go by, I think the year 2020 is totally disrupted by this pandemic of COVID-19 caused by a novel coronavirus 2 infection. In spite of this difficult times, I think the organizer of this conference, Dr. Bansi Sabu, is working hard as the chairman of DiaCare, as well as the president of RSSDI, and he's the person who is responsible for bringing this concept of organizing virtual events in this era of COVID-19, where people from all the international platforms can come together and discuss about recent progress in the field of diabetes, so that we can improve the lives of people living with diabetes globally. As far as COVID-19 is concerned, we all know upon exposure, some people will develop a mild illness. In others, it will progress to moderate pneumonia. and few will develop severe acute respiratory distress syndrome, respiratory failure, septicemia, septic shock, and multi-organ failure. And if you see across the spectrum, there is a lot of use of point of care technology for diagnosis and management of people who are having COVID-19 infection. Starting from screening, there is use of rapid antigen tests. For confirmation, there is RT-PCR tests. For monitoring, there is pulse oximeter, thermometer, bedside monitors are available. And once the patient recovers, to finalize that the patient has developed immunity to coronavirus, you can go for COVID antibody test. So there is a lot of scope for point of care testing as far as COVID-19 itself is concerned. But we will be talking about diabetes and COVID-19. So let's come to that topic. So according to the World Health Organization, individuals, they are at high risk of severe complications or the complications of COVID-19 as well as mortality, particularly when they are having certain comorbidities in the form of obesity, diabetes, hypertension, cardiovascular disease, cerebrovascular disease, chronic lung disease, as well as cancer. And diabetes is one of the most important risk factors for people to have complications, severe illness, as well as mortality when they land with this COVID-19 illness. These are the various papers across the globe. If we go by the first paper, that is from USA, diabetes prevalence in COVID-19 patients was 10.9%. In non-hospitalized patients, it was only 6%, but in hospitalized patients, it was 24%. And people inside ICU, almost one third, they were having diabetes. That means diabetes was associated with severity and need for ICU admission in this cohort of patients. And the same data is there if we go by mortality also, as compared to 6.2% in non-diabetic patients, hospitalized patients. In diabetic patients, the mortality was 28.8%, almost 4 to 5 times higher mortality. The Chinese data says that it was increased from 5% to 16.1% in one cohort, and in another cohort, it was increased from 14.4% to 24.5%. That means presence of diabetes itself, it suggests that if that patient develops COVID-19, then the risk of severe complications, the risk for ICU admission, as well as the risk of death is much higher as compared to the people who are not having diabetes. And this is because of variety of factors. One of the important factors that most of the diabetic patients, they are either overweight or obese, and that is the reason the obesity is associated with variety of other comorbidities. All these things together, they contribute to high risk of complications in diabetic patients. Also, diabetic patients who are already having complications in the form of diabetic nephropathy or cardiac complications, hypertension, or even peripheral vascular disease or variety of other complications, that also add to the problem, and that further increase the risk of complications from coronavirus infection. So if we see, this is the way how obesity, it contributes to severe course of COVID-19. There are comorbidities in the form of diabetes, kidney disease, cardiovascular disease. There are metabolic problems in the form of pre-diabetes, diabetes, insulin resistance, dyslipidemia, and hypertension. And there are various respiratory abnormalities, starting from impaired respiratory mechanisms to increased airway resistance to low lung volume, low muscle strength, and all this, they contribute to severe illness. Whenever these people, they land with COVID-19, the chances of having severe illness, they are much higher. This is the data which says that diabetes, if it is well controlled, as compared to diabetes which is not well controlled. So these are two groups of people. One group is having median HbA1c of 7.3%, where mortality is only 1.1%, whereas the another group which is having median HbA1c of 8.1%, and the mortality is almost 10 times higher, that is 11%. So this gives you a hint that diabetics, particularly those who are not maintaining good glycemic control, they are at high risk of severe complications and mortality. And the same data is there from the NHS England, where they say that the deaths in people with diabetes have more than doubled during this pandemic. And these are the various data. The first data is from Holloman, which says that as compared to HbA1c more than 10%, to people who were having HbA1c of 6.5 to 7%, The hazard ratio was 2.19 in type 1 diabetics and 1.62 in type 2 diabetics. The another data says that as compared to HbA1c less than 7.5, those who were having HbA1c 7.5 or more, the risk of mortality as compared to without diabetes was 1.5% for those who were having good control of diabetes, and those who were not having good control of diabetes, the mortality was almost 2.36 times higher than the non-diabetic individuals. So this gives you a hint that people, if they are having a good glycemic control, that means the risk of complications or severity of illness is much lower as compared to those who are having poor glycemic control. We also know that COVID-19 has got a lot of impact on the healthcare services across the globe and as well as in our country. There is a significant decline in physician office and clinic visits. Both healthcare professionals as well as patients, they avoid this follow-up visits, particularly in a chronic care segment, that is like diabetes, hypertension, and CVD. The use of telemedicine has boosted. There has been a significant drop in face-to-face visits, and therefore a significant drop in diagnostic testing to manage these chronic diseases, particularly diabetes. If we go by, then HbA1c, lipid testing, and all these things, the frequency of that testing has gone down because of this pandemic and because of decrease in face-to-face meetings with healthcare providers. This has been highlighted by WHO in their survey. They have tried to find out what happened to the services for chronic care diseases across the globe, how much they are disrupted because of this pandemic. And if you see this diabetes, almost 50% disrupted, most of partially or completely. And this will translate into a poor glycemic control, and that will translate into a bad outcomes on a short term if they land with COVID-19 infection, and a bad outcomes on a long term because of increase in the risk of complications that will result from this poor glycemic control. Also, there is a change in patients' behavior during this pandemic time. So most of these people, they are now concerned about the impact of this pandemic on their health and economy. Many of the people, they have lost their jobs, their businesses have gone down, and there are a lot of economic crisis for these people. So they have curtailed their healthcare budget as far as their medicines or laboratory tests or healthcare funding is concerned. They have curtailed their budget, and that is translating into their poor glycemic control. There are two group of patients. One group of patients who are economically viable, they do more testing, they follow diet, activity, other things very well, and they control their sugar in a good manner during this pandemic time. And other group of people, because of multiple reasons, they relax, they do not follow guidelines, they do not follow visits, they do not follow testing, and they land in poor glycemic control and multiple problems. We also know that even when there was no COVID-19, everything was normally running, and in those era also, there was only 26.7% of patients they were able to reach the target of HbA1c, blood pressure, and cholesterol, even in United States of America, as per their own data. And the frequency of testing was also very poor. If you see, only 7% they were tested at the recommended frequency for HbA1c testing. This is the data from America. So what will be the situation, or what was the situation in India, one can only think of. So this is even when there was no restrictions, no COVID-19, in normal conditions, still the frequency of testing was less. Can we improve glucose control by improving the testing frequency? Definitely. So people who achieved HbA1c less than 7%, the chances were 2.4 times when the patients were managed in compliance with HbA1c testing frequency guidelines. And this further increased to 5.3 times when, in addition to this testing frequency guidelines, they were managed in compliance with anti-diabetic treatment recommendations. So this is a study which says that 70% of patients who were tested and treated according to ADA guidelines, they were able to meet HbA1c goals, whereas only 30% outside this, they were able to reach HbA1c goals. So just by following guidelines and by doing testing at recommended frequency and by doing recommended anti-diabetic treatment, you can achieve target HbA1c in almost two-thirds of individuals who are coming to the clinic. And for that purpose, this point of care testing has brought a very important revolution or important contribution to improve the rate of testing of HbA1c, particularly in India, in small remote villages. If laboratory facilities are not there, if there is a good clinician is there and he himself is having this point of care testing instrument for HbA1c, patient can come in clinic, consult physician, get HbA1c tested, get other things done, and get his treatment modified. And that is the way forward, that we can reach targets early, aggressively, and we can avoid complications. So this is a data from the primary care practice, where pre-POCT 66% were testing according to ADA frequency, and that was increased to 95% after the involvement of this POC instruments and that point of care testing technology, and this resulted in a decrease in HbA1c levels. So this says that just by adopting technology in the form of point of care testing, you can improve the frequency of HbA1c testing, you can improve the treatment of patients, you can improve their HbA1c, and you can reduce the risk of complications. The advantages of point of care testing, particularly in this COVID-19 times, is that patient revisits can be decreased and unnecessary contacts can be avoided, because patient has to go to one place only one time, everything will be done then, and exposure to more number of people, exposure to more places, that can be avoided, and that decreases the chances of contracting coronavirus infection also. So currently in COVID-19 pandemic, diabetes management which is required is glycemic control should be optimized, and special attention should be given to people who are having poor glucose control, multiple risk factors, complications. But reality is that people, they stay home because of the risk of getting infected with this virus, and face-to-face visits, they are substituted for telemedicine consultations, and because of that, the testing for HbA1c and few other things are going down. People are not also following self-monitoring of blood glucose testing guidelines, and because of that, the risk of a poor glycemic control and the risk of complications is increased. Now I will touch upon this Indian recommendations for in-clinic POC testing, which was developed under the leadership of our organizing chairman of this conference, Dr. Bansi Sabu. I think is inspiring a lot of people, not only in India but across the globe, to come out with latest information related to diabetes, so that we can improve the care and we can improve the living of people who are having diabetes in our country. This was developed by a panel of expert diabetologists from our country, and mainly there were three parts in this document. First is POCT definition, I have already told, advantages and critical aspects, and key recommendations on in-clinic POCT implementation by the panel. So definition I have already given. Ideal POCT HbA1c analyzer should have acceptable performance, standardized to establish reference. Both it should be certified by NGSP, IFCC, simplified operation. Anyone can operate that instrument. It is very simple. I am using it in my clinic since last 5-6 years, and it is very easy to use. Good memory for storage of results, very good connectivity with softwares, and the one instrument can do tests, 4 or 5 kind of tests: HbA1c, lipid profile, glucose, albumin creatinine ratio, microalbumin, CRP. So a single platform can do, with the help of different cartridges, you can carry out different tests. So this is the advantage of this kind of instruments. One point of care instrument can do various tests with the help of different cartridges, and it reports HbA1c in both NGSP, that is percentage, and IFCC, that is millimole per mole units, along with estimated average glucose. And no result should be reported when correct result may not be possible to achieve. So when there is a problem with the result, it will give you an error message and it will not give you any result. Minimization of probability of pre-analytical and post-analytical errors is very important whenever you think of using these POCT devices. So accurate calibration based on barcode test cartridges. Internal quality control checks are there. Operating temperature in humidity range should be optimal. The instrument will check first that if temperature is on the higher side, immediately a warning will come. Works in acceptable HB range, checks for sample coagulation and hemolysis. These are the pre-analytical exercise with the help of technology in these instruments. Additional error minimization is done because there is no sample transportation, expertise-based access for multiple users, and no order variation and no delay in reporting. Once you put the test in the machine in a given slot of time, the result will come out. So key recommendations for POCT from this Indian consensus is that fully automated with minimal manual intervention to avoid errors, operated in clean, well-lit environment with temperature control. That is must, because in India and summer the temperature may go up to 44, 45, and this is not, the machines will not work in those high temperatures. Competent and trained operators for adequate equipment usage, establish internal and external quality control programs, accurate identification of patient while specimen collection is there, storage of reagents and consumables as per the manufacturer's recommendation, provision of equipment for self disposal of blood and contaminated consumables, and maintenance of error log for assistance of any investigation on potential incidents. These are the key recommendations, and many of these recommendations they are followed by this POCT machine by Abbott company for HbA1c, that is LRAF. There is a very good article which was published about this laboratory medicine practice guidelines, evidence-based practice for POC testing, where they have covered almost all the POC testings which are being done in America, and they have given various, they have asked various questions and they have given their recommendation. So regarding HbA1c, they have asked two important questions. First, does the provision of the HbA1c result at the POC level lead to an improved patient outcome when compared with central laboratory testing? And they said there is good evidence to support the use of POCT for HbA1c in both the primary and the secondary care setting. And the strength of recommendation is A. Same way, whether it provides economic benefit, and they say that there is some evidence to show that POCT testing for HbA1c will lead to an economic benefit. This is after reviewing various data related to this POCT testing in United States of America. They have come out with this recommendation. So definitely POCT testing for HbA1c, it improves outcomes and it is going to be economically beneficial. Apart from HbA1c, there is lipid profile, albumin creatinine ratio, and C-reactive protein, and various other things which can be done with the help of POCT testing. But for current pandemic, I will focus only on C-reactive protein and albumin creatinine ratio. Albumin creatinine ratio is very important parameter. It gives you an idea about albuminuria, microalbuminuria, which is a risk factor not only for diabetic nephropathy, but also for the future risk of cardiovascular events. And we all know when to do that. So I will not go in details of that. CRP is very important parameter as far as COVID-19 is concerned. It gives you an idea about the level of inflammation in occurring, and that is very good way, particularly in diabetic patients who are presenting with fever. You may do this test and you may try to identify whether they are having inflammation or not. And there are various guidelines which recommend that CRP is one of the important parameter to be investigated at frequent intervals in people who are having this COVID-19 illness. And it gives you an idea about prognosis, about the risk of complications, various other things. I am not a specialist in COVID-19, so I will not go in detail. But CRP can also be done with the help of POC testing. That instrument can give a result within few minutes. Put a drop on a cartridge and that will give you an idea about CRP level. So to summarize, I will say people with diabetes, they are more likely to experience severe complications and high mortality, particularly when they land with this COVID-19. And if they are having good control of diabetes, then the risk of complications is less as compared to those people who are having poor control of diabetes. And complications of diabetes, they also work as an additive risk factors, particularly when they land with this infection. So regular diabetes management, regular HbA1c monitoring, and good control of diabetes is must for diabetic patients, particularly in these times of COVID-19. And this can be achieved with the help of point of care testing, by improving the frequency of HbA1c testing, one can improve the treatment, and one can achieve good glycemic control and try to reduce the risk of complications on a long term basis or on a short term basis when they develop COVID-19 infection. With that, I thank you again, Dr. Bansi Sabu and team, for making me part of this prestigious conference of 2020. We are coming to the end. We hope that in 2021 we will not do it virtually. We will be there face to face meeting with all of you. Thank you. Thank you very much.
Thank you so much, Pratap sir, for giving a very good lecture on POC. And we are also fan of this machine. We are using for the last 7 to 8 years. In Central India, I was the first to install this machine in my clinic. It's so friendly machine that my patients are got fan of this machine. They used to come directly to see me and say, "Sir, वो वाला test करो जो आप यहाँ बगल में करते हो." That's why I've kept this machine in besides me, just besides me, and there is no error because you are pricking the patient, you are taking the sample, and there is no lab error in that.
Yes.
So I second your opinion. And POC has trusted, given a good trust at this bad COVID time, and we are able to decipher them. With this note, if there are any questions, Dr. Purohit, you can ask.
Yeah, thank you very much, Dr. Pratap. Your presentation was very much interesting, and it has opened up all the details, and everything was very, very clearly mentioned about the point of testing machine and the role in the COVID. So thank you very much for your lucid presentation. So we can, any other, Gopika, any questions are there?
No, sir. Thank you. Thank you so much.
Okay.
Okay.
Thank you. Thank you, Gopika. Thank you, Dr. Suresh, Dr. Raka.
Thank you.
Thank you.
And in the interest of the saving the time and be on time, we can move on to our next speaker, Dr. Archana Sarda. So can you load the slide? Yeah, Dr. Archana Sarda is a well-known diabetologist, endocrinologist in the Aurangabad city. She is chairperson at Sarda Center for Diabetes and Self-Care, Aurangabad. She is a consultant diabetologist, founder of UDAN, an NGO for underprivileged children with diabetes. And she has been a member of the National Type 1 Diabetes RSSDI Task Force. So I will invite Dr. Sharda to go ahead with her presentation.
Good evening, and I am so happy to hear. It's always a pleasure to be in Diacon, this time virtually, and hopefully next time it will be definitely physically with my entire team, which we always do for, especially for type 1. So I will begin my talk now, which was the role of technology to unravel the mystery of type 1 diabetes. And I'm very happy because I'll be saving time, as Dr. Julia and Dr. Anjali have done 50% of my job with the detailed talk about SMPG and the apps which are available for it, as well as CGMS. So I will not have to focus now on the science of it, but it's very, very important now to focus on the type 1 diabetes aspect. I think most of physicians attending the conference do not actively see many type 1 diabetes children or adults. They are few maybe in number, and there are selective centers, of course, who are giving very credible, very optimum care to most of the type 1 children and adults that they receive. So this mystery of numbers that we see is something I just wanted to sensitize everyone to the actual what happens from the perspective of a caregiver and a user. So we often are not able to see the other side of it. We have been talking about in perspective of type 2 diabetes, where people are more structured, they're adults, there is a space between testing and going to the doctor. It can be once in 3 months, once in whenever required. But when you see the world of type 1 diabetes, where every day of your life is a science experiment, and if anyone who is now taking care of a person with type 1 diabetes will totally understand that and accept that every moment is different, every challenge is different, and so many factors are affecting the blood sugar of a person with type 1 diabetes. So these memes were made by type 1 studios, and I just got them because they so aptly represent the situation. And unless and until we are very familiar with this situation, we are not sensitized to the thought on what a wonderful change technology can make, especially in type 1 diabetes. For every other thing, imagine the day starts with how many decisions? I mean, I have just listed a few, but 24/7 it is decision making. What am I going to eat? When am I going to eat? I mean, we also make that decision, but with as a person with type 1 diabetes, it is also appropriate food, appropriate time, when and what activity. So if there is a spontaneous activity, it is not just you get up and go. There's a lot of calculation involved. Then counting the carbs. I mean, these are the kind of calculations which baffle so many people, baffle doctors. But look at the ease with which the people with type 1 diabetes actually do them and incorporate them into their day-to-day life. And we expect them to do that, which is pretty tough on maybe 1 day, 2 days, 5 days, forever. Then when to check your blood sugar, how much insulin to take, and all these come together, and then you interpret all these. What am I eating? What is my activity? What am I carb count? Do I check my sugar again? How much insulin do I? And I'm not even talking about the changes that come with the mood or with lack of sleep or excess of sleep, stress, menstruation, sick day. It's a long list. So this was just to put things in perspective that we are very much dealing with a situation which is different in a person with type 1 diabetes than a person with type 2 diabetes. So all these advances have been there for quite a long time, but technology in the last 10 years has really come out with rapid advances. And what are the core outcomes that have come out? So I'm talking in context of care especially, is improvement in glycemic control. This is ultimately what, as a treating physician, is what we would be looking at. At the same time, we are very focused on reducing hypoglycemia, because as we all know, we have been talking about it today, the tighter the control, the more the risk of hypoglycemia. Then reduction of the risk of acute and chronic complications, which is understandable as a result of better glycemic control and reduced hypoglycemia. All this automatically, along with having a gadget to use, not having to break. Those are the icing on the cake, actually. They have an improvement in quality of life. And as mentioned by Dr. Julia and Dr. Shelley both, was individualization of care is possible. Who needs which technology, how, what often, what is their specific requirement, and hence we can change it. So what are the technological advances which are specific to type 1, which has changed their life, which has really unraveled the mystery? So the single most important aspect is glucose monitoring. Of course, insulin delivery, glucagon delivery, and all the apps or applications and algorithms that integrate these technologies have made a wonderful change. This is not, there is not enough time or the platform to be able to talk about each in great detail. But my purpose today for the talk was to sensitize the physician audience, especially, that how a type 1 can benefit from these technology, and whoever can have it should be benefited for, should be offered a choice, and what all is available. So the guiding principle, I found this very interesting, was you think like a pancreas, right? So once you start thinking like a pancreas, and technology helps you to think like a pancreas. So glucose meters, very early 1971, the first blood glucose meter was made, and that made SMBG a standard of care. I mean, for us who, I think we can't even begin to imagine what life was like for a person with type 1 diabetes when they used to measure the sugar or put the blood in a test tube, see the copper sulfate, the reagent, and how would this possible and how often could they have done it. But this SMBG became a standard of care after 1971. But the contemporary glucose meters have also come a long way, because as we know, because of the cost, not everyone is on a CGMS. So for type 1 diabetes, the glucose meters have become very small. They come in 5 seconds. The use of 3 to 5 microliter of blood only. They are capable of wireless connections via radio frequency or Bluetooth to insulin pumps or smartphone applications. This was talked about, and yes, most of the glucometers today with Bluetooth can be downloaded when a type 1 family comes in. And you know that children are so, especially teenagers, they like to fudge the results. They would not like to tell the truth. Sometimes they would hide it from their parents because they get scolded. These are the times when you just, anyway, for analysis, it's great. But even for this aspect, when you download it, it's just very simple in a clinic on their visit, or direct connectivity as has been talked about. So Bluetooth devices has really changed the way we can integrate the end systems, because you can connect across different types of monitoring and devices. So it is not specific one, and that is the way we want more and more technology to be. All the applications, there's an app for everything today. So apps can automatically receive values and identify trends and share data with clinics in between visits. So this is something that has really made a difference, because, and self-analysis. If you see young people with type 1 diabetes today, or adults with type 1 diabetes today, they would have their own app, and they would not have to feed in. Of course, there are lots of apps where you can feed in the food, you can feed in your exercise, your activity, your everything, all parameters, blood pressure, everything can be fed in, including blood sugar levels. The other apps are connected through Bluetooth to your glucometer, and then they can actually absorb it. There are so many apps where you can take a photograph of food and ask for a carb count. So there are n number of apps available. The purpose here is to really look at it and find something which can coordinate, which integrate with the glucose meter to get the best kind of outcomes. So if you look at the right side, so this is just a meme that I found very interesting. Imagine what child's life is like. The parents are saying, okay, kids, instead of finding Easter eggs this year, we're going to find all the test strips hiding around the house. So life is like lots of testing, and there's everywhere. So they have and to a time where we have a CGMS. So this is a real game changer amongst all the technology, CGMS, which made the game changer and changed the mystery got unraveled of what is happening to a person with type 1 diabetes, sugar. So the first CGMS came in 1999. And since then, of course, the technology has improved, and we have heard today from Dr. Anjali how amazingly we can do this. But a type 1, I would just like to mention that this understanding of glycemic variability becomes absolutely paramount. Because as I just mentioned, you're talking about a small child, a child in pubertal spurts, you're talking about teenagers. Everyone has a flexible lifestyle. They are still in the growing phase. So many factors which are changing their blood sugar, which are not in their own hands. And you cannot give, and one should not give, a very rigid kind of a plan to a growing child. So if we look at people with type 1 diabetes, it just not only gives us a complete understanding of the variability, it also helps us to give flexibility to the person to adapt to that variability, and not so that it becomes stable. So examining glucose every 5 to 15 minutes allows to assess trends and patterns. This has been discussed, to assess the percentage of time spent in range. Now we're going to talk about time in range in context to type 1, which is probably the biggest emphasis, which is again a game changer on how we take care of our children with type 1 diabetes. Now the changing levels are very rapid in type 1 diabetes. So anything, a small thing can be a trigger. And if that can be accounted in the real-time CGMS, imagine a child goes to a party. Imagine a person with type 1 diabetes is playing cricket or football, is trekking, has some birthdays there and some. So if that rapidly changing level can be accounted for and a correction given, this gives so much of freedom to a person to live the way they want to be. These CGMS can be used standalone or can be linked to a pump. So if they are linked, and that gives a very interesting a logarithm which is used, and again, artificial intelligence is being used to make recommendations. And as a result, there are so many benefits that we are going to see later. So this can provide predictive alerts up to 60 minutes in advance for potential hypoglycemia and hyperglycemic events. Imagine a student in school is in class, or there's a games period suddenly, or there's a alarm system, because the child may not remember that it is time to snack, time to do this. So the kind of safety this allows, the kind of predictability that allows, these alarms, alerts, are of most benefit when you see in context to a person with type 1 diabetes. For a little while, let's try walking in those shoes. Imagine, we always as physicians feel that there are symptoms, you should take care, you should have a structure. But imagine a person every day not sure if the blood sugar is going low or going high, because sometimes the symptoms fudge up, sometimes it's unpredictable. On a sick day, do you have a high sugar or a low sugar? After exercise, is it high or low? It's not so predictable as we think. And when we walk in these shoes, then we realize what all gets missed. So with SMBG, we have seen these slides with the previous speakers, but these are the missed blood glucose levels. So even if we were doing a very frequent finger stick test, right? So these were the peaks, the lows, and the other time, which would be anyhow missed. As was talked earlier, but I would like to specifically talk about HbA1c, which is still a gold standard. But now we have moving on to time in range, because look at these three different scenarios. The first scenario, HbA1c of 7, which was the goal and average of 154, was actually 40% of the time high, 20% low, and only 40% time in range. The second, 70% of the time it was in range, 25% was high, and 5% was low. And look at the third one where it was completely in range. So all three were HbA1c of 7. So in a person with type 1 diabetes, this becomes all the more prominent because there are so many variables as we have seen. So time in range becomes a very comforting factor, because when I see my children with type 1 diabetes and they say, am I never going to get it like every reading right? And now they know it doesn't have to be every reading. So even with SMBG, one can calculate the time in range, but for that one has to have more than 4 readings per day. But if you look at this time in range, which Anjali mentioned in the previous talk, so if 70% of more are in range, it is comforting that they will not get complications and the targets are clear. So minimizing things below 180, trying to make it less than 4% below 70, and maximizing between 70 and 180 is a target. With CGMS, it becomes so obvious. So even if we can't do maybe a continuous monitoring for therapeutic care, then maybe a diagnostic CGMS once in a while, which is cost friendly, pocket friendly, just to know your trends and set your doses and set your patterns. So there are proven benefits of CGMS. There is improved control in type 1 diabetes, decreased time spent in hypoglycemia or hyperglycemia, which is very often missed in type 1 diabetes. And if you're doing just SMBG, there's a decreased risk of complication as a result. Substantial improvement in higher baselines HbA1c specifically is seen, and substantial improvement in those with frequent sensor use. So I also see this in my clinic when we see patients who do diagnostic CGMS, even they benefit because they are able to set their doses. They come to know of nocturnal hypoglycemias, what happens in school, what happens with the evening snack, which is otherwise missed, even if you're doing a 8-point SMBG. But the ones who are on a continuous CGMS as a therapeutic tool, they are doing so much better because real-time monitoring can really change the way they take care of themselves. So coming from the technology of CGMS and SMBG, which is really the main mystery unraveler, I would say. Very quickly, I will just go through it. It's not possible because I think there's another session tomorrow as well on this, and insulin pump is a vast topic. Just suffice to say that it is one of the most advanced technology wonders. So most of the people I used to meet earlier used to say it's a way you can avoid pricks. And that is exactly what we want to tell everyone. That's not all about it, right? So I know people who have started a patient on pump just because they did not want to take 4 to 5 picks a day, which is not the right reason. because these are also the people who will then not do carb counting, will not monitor enough, will not integrate the entire information. So insulin pump is way beyond just the pricks. The whole, especially if one can have a continuous glucose sensor and use the control algorithm. So nowadays we have so many kinds of pumps. The first one came in 1974, which was too large, but commercial pump came in 1980. So it's like been a long time. And in 4 decades, it has shown amazing improvement. Studies have shown benefits of improved control, less variability, decreased hypoglycemia, improved quality of life. We all know that today there are pumps which are sensor augmented pumps. You have alarms for lows. You have a pre-alarm. It can suspend before it can go into a low. So imagine a small child, imagine a teenager who is out very active, imagine somebody who has brittle diabetes, even a pregnant lady with type 1 diabetes. These are people who absolutely benefit from an insulin pump. There are so many types of pumps. I'm not going into that, but I think it's very, very important that every physician knows that this is an option. We often think money is a limitation, but we'll be surprised on how many people would somehow manage to spend for something like this, which improves their quality of life. It is absolutely not that simple. So if you see a person doing bolusing themselves on a pump or using a CGMS, the calculation is no less than really quantum physics and string theory. So just calculations, you have to know your insulin sensitivity factor, you calculate your own carb counting, and then decide your bolus, whether it's a correction bolus. So all this becomes easier when we have lots of applications and algorithms. So when we try to work on these, there are so many. There are some Indian ones, they're across the world. So whichever app we use, whichever algorithm a particular machine system uses, but it's very, I feel my purpose here was to sensitize that these are available. And as per our requirement, are we looking at something which also takes into our diet, exercise, and other parameters? Are we looking at something that just gives us graphs and tells us our trends? Are we looking at something which is real time? So whichever we feel is good for us, just logging, but there are lots of apps and algorithms available which can make such string theories simpler for us, give us a direction, and help us to bolus correctly in the type 1 diabetes. So at the end of it, I think if we look at this whole scenario of technology, which sometimes is overwhelming, but if you look at it from a perspective from the caregiver, imagine a parent who says when there is this cupcake, the blood glucose is 114, the carbs are 45, bolus 1.3, and that he knows or she knows that my child is alive and can eat this. There is no value, no amount of money value, monetary value that we can attach to it. It is a priceless feeling to be able to give this kind of freedom to our child to live to their full potential. So technology overall has really come a long way in giving a better quality of life, freedom, growth, outcomes. And if we have to step into those shoes to realize what a huge impact beyond medical care it makes in a life of a person with type 1 diabetes. Another thing which I just wanted to mention is also the glucagon preparations for type 1 diabetes, which are very important. Earlier, we did not have them. Now these are US FDA approved. There's a hypopen as well as nasal glucagon. So that's another part which is absolutely important for type 1 diabetes. So I would like to conclude by saying that technology has definitely given us insights and tools like never before to provide optimum care to a person with diabetes. And this care we experience every day. I deal a lot with rural type 1 children, and my children in their fields, when they get up at 4 a.m., they are farming, they're walking to school, but having a CGMS gives us insights, and we are able to then plan their insulin, their monitoring, interpretation, nutrition, everything accordingly. So whether it's urban or rural, it makes a huge difference. But individualization of which technology will benefit whom is very essential. It is not just based on the monetary aspect. It is also based on what is needed, what is the problem area, and is it going to benefit? But whatever we do, motivation and education remain the cornerstones of type 1 diabetes care with or without technology. Even with technology, unless a person is highly motivated and is willing to be educated in the right way of integrating the knowledge of carb counting, of insulin pump and CGMS, and doing it in a motivated manner. Because without this, that technology will become redundant. So with this, I conclude, and I totally appreciate the efforts of especially Dr. Bansi Sabu in making a difference in the type 1 space in our country through RSSDI, through various platforms. This is a picture of the first one-up challenge, which went to Kalsubai, 23 students with type 1 diabetes from all over the country. Almost 30% distribution were there. Some were on basal bolus without any technology, SMBG. Some were on CGMS, and some were on pump and CGMS, but all did very well. Education and motivation was what made the difference. And of course, when we studied, it was much easier for the ones who were using CGMS and the pump. Thank you very much. I would be happy to take any questions.
So thank you very much.
Thank you so much, Dr. Sarda. You are the feather of that Udan. So, so flawless presentation and so philosophical presentation. You have to walk on that shoes. It's a great thing you have said. And I just want you to share what you will say as a poor man's SMBG equivalent to CGMS. Because patients are coming from rural area, what 4-point parameter you suggested? What were the 4? Which time you suggested? Major meal? What? Yeah.
Yes. So with my children with type 1 diabetes, we have developed a program of SMBG, which we call
Sorry. You lost connection.
I think she lost connection, so we'll wait for her to come back. But meanwhile, it was an interesting presentation where clinical as well as technological aspects were taken care of, including the newer technology and what's going to come in the future.
Shall we take questions to the end, sir?
Yeah, just check if there are other questions.
No, we don't have any questions.
Try to connect. Try to connect. We can wait for 1 minute. We are on time.
Okay.
Professor Peter has joined.
Yes, I'm here. It's a great honor to be here.
Yeah, sir. We are feeling great because of you. You people joining from the globe, throughout the globe. We are feeling honored.
But it was just a very good presentation about type 1 and apps. This was very good.
Very nice. She's working with type 1 diabetes. She has an NGO of Udan. That's why she's doing such a great job.
Yeah, and she is basically working with underprivileged children.
Very good.
Yeah.
Yeah, children having insurance and getting supplies free of cost and all is different story than working with underprivileged people where every moment is a risk of so many things. So it's really, and it is in the central India where the temperature varies a lot. In the summer, temperature goes up to 40, 45 degree, or maybe
Aurangabad.
More.
Yeah.
Aurangabad, yeah. And
the last picture was Maharashtra's biggest peak, Kalsubai, where the type 1 diabetes have chased that peak. Yeah. The last picture that she has shown.
Yeah. I think this is so important with the underprivileged people, because this at the end differentiate whether we are real physicians or not. If we are able to take care about social minorities, underprivileged people, this is important from an ethical point of view.
Yes.
So, Dr. Raka, I think she is not able to get connected. So we can move on. Yeah, you invite the next speaker.
Yeah.
I just wanted to share my screen.
Yeah, Dr. Professor Peter Swaj, Professor of Prevention and Care of Diabetes, specialist in internal medicine at the Medical Faculty Carl Gustav Karus and Habilitation Center, Habilitation in Internal Medicine. Peter Swaj has 252 peer-reviewed publications, a grand accolade. His citations include 15998 articles, so much without self-citations, and are represented by Hus Index 52. He has written 42 book chapters. Peter Swaj, we are more than happy to share screen with you. Peter Swaj has invited to more than 350 presentations to peer-reviewed internationally established conferences, and his lecture will deliver all kind of wisdom which he has got in this field. Next to Peter Swaj.
This is a great honor. Thank you very much for your introduction. It's always interesting to hear someone else introducing yourself. And so it makes me a little bit shy after your presentation. But on the other hand, it's a great honor to be here and actually to speak from Germany to India in this also a little bit difficult times for any one of us. And I liked the previous presentation a lot because it was highlighting the power of digital tools for patients with type 1 diabetes. And what I would like to do is adding another top, because I'm totally agree with this previous speaker, but I would say the power of digital tools differentiate how good they are able to help our patients through their lifestyle. And if you talk about lifestyle, we are directly also in diabetes prevention, because I see a big future, actually a disruptive future in the diabetes sector for digital tools. And again, I thank for the introduction, and I would like to highlight the last line, because I'm currently chairing a large working group from our European Diabetes Association and the International Diabetes Federation with the idea to push the development and the implementation and also scalability of digital tools for our diabetes patients, but also diabetes prevention. And we want to push this actually from the not from the physician's mainly point of view, from the patient point of view. And this is something else what I would like to add to the previous presentation. COVID-19 is driving all of us. We actually have very, very high numbers in the state, in the southern state of Germany currently. And it changes a lot of our views onto our practical medicine, but it has also changed our view on the use of digital tools. Because if you see here 550 people from Facebook, all the red ones developed diabetes through their lifetime, but there are some green ones, and the green ones were able to use digital tools empowering to better self-management and help them to avoid diabetes from developing. And this is what I would like to go through with you. There are big new opportunities, and the previous speaker actually has mentioned all of them. There is a lot of mobile devices now available all over the world. There are a lot of applications who help the people in their lifestyle, in quality of life, to empower the people for better self-management and assisted decision-making. And I think this is a big opportunity for diabetes care or the care for any patient with chronic diseases. But I think they only meet this criteria if they are able, on one side, to inform the patient, and this is what we just have heard from the previous presentation, by giving a feedback, by storing the data, by analyzing the data, using artificial intelligence to present the data in a different way. But this is not all. They need to be able also to help the patient, to motivate the people to change lifestyle. So using digital technology to motivate people at the end to meet the third criteria, to change behavior. Only then I think they will be successful. We know it from all of us. If you download an app on our smartphone and we don't like the app within the first hour, we delete the app again. So the patients are also brutally honest in the digital field. If they don't like what they have on the smartphone, they will not use it. If the physician tells them to use it, but they don't like it, they use it in the adherence is low. So this is a challenge for the development of those digital tools. And another challenge applies, and this is ADA and EASD saying, what is our role as healthcare professionals? We should be knowledgeable about this digital helps us and their strengths and weaknesses. We should know how to use them in medical care and prevention, and we should use the data for our daily work. And if I ask you, all the people attending this conference, are we aware about all these apps? Are we knowledgeable about all these apps? And I think most of us will say, no, we are not. Sometimes our patients are better educated in using these apps as we are as physicians. At least this is the experience we have in Germany, because there are a lot of different views on digital tools. And this is, of course, and this in my mind is the most important. What is the user saying about this digital tool? Is it a bolus calculator? Is it an app helping to improve physical activity or dietary behavior? The user, the patient first decides, do I like this app or not? Then this was mainly what we just have heard in the previous presentation. What is the healthcare provider view? And then the patient view comes, but the patient first is a user and is not first the patient. Then the peer group, behavioral aspect and other aspect. And I'm sure there are many aspects we even don't know yet. In my mind, as better we are to meet the intuitive need of the patient, as better we are in helping the patient to use the product and change behavior. And this means, or leads me to the question, how are we changing behavior? Because we are not different than any patient. And if you look here, if a patient has cancer or pneumonia, the patient normally will follow us, what we say as a physician. If you talk about diabetes and obesity, we as physicians are out of the game in driving or directing the patient lifestyle. The patient will trust us and he will follow us what we recommend him, maybe for 1 or 2 days, because then there is a more powerful group taking over this reflection, and this is the patient peer group. So the peer group of the patient is more powerful in terms of lifestyle of the patient than we as physicians are. And what is driving the patient in changing behavior? It's purely quality of life. So if we apply this, then this means using digital tools, they must be as good as that they are used in the peer group, that the peer group is supporting this, and that the patient feels within 1 or 2 days that it's improving his quality of life. And this is a big challenge, but I'm very sure we can meet this challenge. If I then say apps should be able to help the patient to change behavior, we must study how does behavior change work. And here you see a model we have developed in a large European initiative. There are 3 main blocks. This is motivation, action, and maintenance. But each of these blocks has different stereotypes of patient, different circumstances of what is needed. But there are technologies or techniques from psychosocial therapy we can use, like motivational interviewing, reflective listening, SMART goals, importance ruler, and so on. We can use to guide the patient through this change of behavior. This is easy if you do it from eye to eye with the patient. But is this maybe a chance for digital tools to apply this technology, to apply behavioral science techniques into digital applications to help the patient to change behavior? And I'm sure if we meet this criteria, we will be successful in prevention and improving care of our patient for diabetes. In my mind, digital support means not that the patient has a problem and he uses the digital tools and the digital tools is doing something. We should rethink the strategy and say, it's our goal to support our patient digital. And so the support is the main thing for me in this sentence. It's not that it's digital. Digitalization is only a technology, but what is the quality behind the tool? It makes a difference. That means we have to act innovative and we have to think about acceptability for our patients. As I said in the beginning, the patient is brutally honest. He's downloading an app, he's testing the app. If he don't like it, he's deleting the app. And we should think about how can we make those tools as acceptable by addressing the need of the patient for our needs in diabetes care. We are often talking about digitalization, but we mean telemedicine. We mean downloading data from a glucometer, from an insulin pen, from other sources, and mirroring it back to the patient in an aggregated manner. This is banal telemedicine in my eyes. And this is actually old-fashioned digitalization. But if we add feedback and intervention to this data, for example, using artificial intelligence to make use of the data, to give the value to the data, then we can translate this into better care. In my mind, this is mHealth as mobile health and smart health in applying this data for better quality. So how can digital innovation help the patient to improve self-management? And we have asked about 4,000 patients, and these were the answers the patient gave us. Of course, some of them mentioned interconnection with diabetes tools, but other mentioned gamification, other mentioned decision support, interaction with Facebook and other social media, and those were often more important than the pure disease-driven applications. So how can we make use of this for us? If we discuss the pros and cons of apps and digital tools in diabetes care, following what the WHO is saying, there are a lot of pros in terms of motivation, safety, giving a direction or improving adherence in diabetes care, but also supporting independence of self-care for the patient. But there are also downsides for the app, and we should not forget that the literacy of using the app is very important. And this is not only diabetes literacy, it's also digital literacy. So often the elderly can learn from the young people in terms of literacy, but this is an important point of acceptability of digital tools for our patient. If you go through, this is number one in my mind. The apps can help to support the patient in changing lifestyle for better diabetes care and prevention. And this is reducing the risk of prediabetes. It's so simple as if digital tools is supporting the patient to be more physically active or change dietary habits, it really can prevent diabetes, and it can be more successful than what we have learned from the big diabetes prevention trials. If we move into other aspects, adherence to medication, adherence to a lifestyle, adherence to a new learned habit can be very powerful by using this aspect. And cost is becoming an issue. Good apps, some of them are totally free available. Sometimes we don't know about the quality of these apps, but it can be very cheap in costs for patients, especially vulnerable minorities. But it also can be the opposite. We are just experiencing in Germany that we can prescribe apps as physicians, but they are sometimes 3 or 4 times more expensive than some medication. Finally, interaction with a healthcare provider. This is what we would have loved if we would have had it in the Corona pandemic, having contact to our patients through the pandemic by using an app. Geographical barriers and psychological aspects I already have mentioned. So what are potential barriers? Yeah? Electricity, literacy, stigmatization are points we have to be aware. So a digital tool is not meant to be applicable for any one of our patients. I think we need a bouquet of different tools addressing psychosocial needs of our patient. So there is a ladder of where one step builds on the other. Monitoring, it may start with it may go ahead with some disease-specific aspects and additional features driven by the need of the patient. Here are examples. And if we look at the number one, it's behavior change. So if an app is sustainably valuable for diabetes care or the care of people with chronic diseases, it is only then if it's addressing a behavior change for the people. Or, for example, we had this example with self-monitoring of blood glucose. If it helps the people to drive decision or helps the people to adhere to a therapeutical behavior. So I would like to give you a small example how digital innovation can help. We push our patient or we force our patient to measure glucose, but we random or seldom ask how often the patient understands the value which is coming out. And there are studies showing that 70% of our patients do not understand what means the value of glucose level, and they are not able, 54% are not able to correctly react on this glucose level. So there is a difficulty in literacy in understanding the value. And can digital technology help? And this is one example with a smart-like technology, like the glucometers, will give the glucose value as in color. Do you see the pattern here? That this helps? Or do you see the pattern now here? This is actually easier. This is what our patient is seeing. That this helps? Or this? Or maybe this is preprandial. Do we actually need the numbers? Or is it enough like this? Or like this? This was a very simple example, which is working in some patient groups very actually ideally, that we switch away from educating the patient to use the numbers and to act on the numbers, translating this into colors, but make the colors actionable, because the traffic light system, it's an actionable color association all over the world. You have to stop, you have to go, you have to wait, you have to be aware of. And highlighting the glucose values in making it actionable for the patient to walk, to drink or to eat something because of a hypo, or to spoil the patient as he is in an excellent frame, would be the right way to go ahead. So the colors in this might give a meaning to the numbers, and this was only possible by connecting apps to the glucometer. So you measure your glucose and your app tells you how good you are or what you should do. And this is extremely helpful for many patients. It's about 38% of the patients are directly improving their lifestyle. And this can be translated into a lowering of A1C by about 1.3%. And this is shown here. You see how lifestyle can reduce A1C, how our glucose medication lowers A1C. And at the end, you see how our digital interventions can lower A1C. And we see the last column is about the same as good as lifestyle intervention. And this were the newer digital tools developed. And this is the power of digitalization. If we are able to help the patient to change lifestyle by using digital tools, then they will be valuable. Then they will have an added value for diabetes care and prevention. And how does this work? I mentioned already the different stages of readiness to change lifestyle. What we are driven as physicians is to understand the morbidity of our patient. But what we have to learn is to address more the intuitive need of our patient. Now imagine this three-dimensional structure. We can position each stereotype of patient in this network. And if we bring this together with all the digital tools and data available for our patient, we can build a competence toolbox saying we assess the readiness to change lifestyle. We bring it together with digital tools. We call it risk stratification. And now we have available 100 apps and 100 interventions on the market for this patient. The analysis of this data will tell us which of these tools will be the right one for our patient. And I think here is an example where digitalization will make our life much, much easier to help the patient to improve. This is an example from our COVID-19 experiences, how to use digital care in a stepwise guided procedure. If you have a lockdown situation or pandemic situation, to reach our patients at home, to work with our patient using digital tools at home. You can find this at this reference, because I think smart health, it's the final topic of digitalization, will be disruptive. This could be as digital education for our patients. So having a comprehensive digital diabetes education program, which is following the daily behavior of the patient, which is following the need of the patient, and is done purely digital. It can mean that we have to address the aspect of accessibility and acceptance in a different way. This is an analysis we have done with one of the apps developed by us. And the patient ranked 61% of quality of the app, not because of risk aspect, because of gamification aspect. So they liked it because they could play with it, and this defined adherence. And the patient is saying us what they expect from an app, from a social health profile. And if we want to go deeper into this and use this diagram to assess different products, we have here one example. It's Diabetes M. It's a standard diabetes app. It could be one of the apps from the previous presentation. And if you look at the social health profile of this app, it gives you an example. If you go to another app, it's one app we have developed for diabetes prevention in Germany. It gives you a totally different profile. So these are social qualities, social aspects for ranking an app. And if you go to the app, which I just have mentioned with the colors, we get, again, a totally different profile. So there are different social qualities and profiles of the different apps, and each of them is applicable to a different stereotype of patient. And this is the new future of diabetes care, of qualitative and innovative diabetes care, that we have this in mind. So one app addressing these qualities, the next one, other aspects, the third one, those aspects, and this can be 3 totally different patients. So if we look at these examples, what I just have mentioned, this one app, Anchor Steps for prevention, another prevention app we have developed in Germany. It's a success story by working together between universities and private companies to launch this and to make it available for a cheap price to our patient. And what was driving us? We asked our patients what they want. And then we looked at the different stages of readiness to change lifestyle, like motivation, action, maintenance. And we ranked this quality of features, what an app should have, based on this need of the patient. But we went ahead and said, okay, morbidity is also driving quality. And we sorted the features again, following this. And then finally, based on addressing intuitive needs of our patient, social support for performance and costs. And this at the end turned it into a profile of a digital tool which really can support our patient. And the optimal diabetes prevention app, in my mind, would include all these features which are written down here. This app doesn't exist, but maybe in the future, driven by the power of the pandemic, there is a lot of energy to develop new tools. The future of health, in my mind, will be not addressing glucose. It will be addressing a behavior change for our patient. And at the end, if you are interested to hear more about this, we have developed at our university an online diabetes education program for healthcare professionals. It's called ONIT Pro, and we are launching this together with Ascensia. But the program was totally independent, developed by our university. And you can go to this website or using this QR code and you get this program totally free. There's no charging for this program because we want to have a program with no barrier of accessibility. You get an access code, and so only your access code is seeable to us. And you can go through a program which was, as I said, independently developed by experts. It's accessible by any digital tools you can have. It covers the whole range of diabetes knowledge, including COVID pandemic, including digitalization. And if you go through, you get a certificate from our university. So this is the description of each of the modules, like a digitalization module. You find some slides, you find a video, you find at the end some CME questions. It looks like this, what I have shown you, and you find some of the slides from my presentation again in this online portal, and you always will get back a very practical recommendation for your daily work. There are 32 modules of diabetes knowledge. It takes about 45 minutes to attend one of these modules, and it's covering the complete spectrum of diabetes knowledge. And if you pass 21 modules, you get a certificate. This is a QR code. If you are interested, you can register there, then you get an access code, and then you can participate in this program free of cost. There is no association with any commercial activities from a company, even if we are working together with Ascensia to scale up this program. So my final message, let's work together. You in India, you have totally different experience than we have, but 90% of our experience are probably very, very common and very similar. And if we learn from each other, if we work together, then we are finally available or able to walk away from diabetes. Thank you very much. It's a great honor to speak here. Thank you very much for your attention.
Thank you very much, Professor Peter. It was very, very interesting to get insight what you have created and your university is offering to the society. I'm really very happy, and we will definitely take advantage of this option, and we will go hand together. So thank you very much for
Thank
your.
you very much.
Yeah, Dr. Raka, can you take on further, or if there is any questions?
Yeah, Dr. Professor Peter, we are more than happy to have chair with you session. This session was so important, and you have shared very nicely use of artificial intelligence and use of digital apps. Yes, we are moving towards the era of artificial intelligence, and if you are going to use it meticulously in our setups, then definitely we can able to reverse diabetes in a better manner. So many patients are like that. They are not well acquainted with these apps, and if we in all our clinics we have any universal type of clinical apps, then patients do get benefit from that. In Germany or in India, diabetes is same.
Yeah,
we are suffering from same kind of problems. You people are developed, we are facing underdeveloped societies, but the challenges are same.
yeah.
Patients in educated society are also not very well eagerly accepting all these complications and all. Like rural patients, if we talk about differences in acceptance and perception, our rural patients behave well. If you talk and preach them diabetes, patients are not behaving very well. If you talk about the effects and legacy of diabetes, so this happens all over the world, and it's prudent to talk about artificial intelligence in such a very flawless manner with so much pictures, so much arithmetics and everything you have shown. Yeah, it was a real very good presentation, sir.
Thank you very much.
Gopika, you have any questions, please?
Yeah, wonderful lecture, Professor Shorts. I have one question. Do you think there is an increasing trend in the uptake of these digital apps during these COVID times?
We see it already. Not only now, we saw it already months ago with the COVID pandemic. We were actually so sad that we didn't have good educational digital tools in Germany through the pandemic, because we were not allowed to educate our patients ourselves because we were in a lockdown situation. And this has pushed a lot. And since May this year, we have a law in Germany that you can license an app similar to a drug, but you have to undergo the same licensing process. You have to prove with clinical studies and so on. And the first 4 apps are already available, which can be prescribed. One of the apps we have developed is also available as a prescription. And this is pushing the field in the moment a lot. And the German state says they will reimburse the use of this app. We are not fully sure how this will work. Is it depending on how long the patient is using it, or is it depending on outcome? It will be decided in the next 2 months. But we don't have a data on it, but my gut feeling would be that we have today 3 to 4 times more patients using apps in diabetes care than the beginning of this year. So the COVID pandemic actually is an enormous push of using digitalization. But it's also, it separates a little bit. It's more on the field of educational tools, on communication tools, on digital apps, keeping contact to your physician and so on. It's not the bolus calculator, but there's also an increase because as more the patient start using digital tools, they start using more and more digital tools. So there is an uptake on all of this.
Yeah, that looks really promising.
Yes.
So, Sas, We are on time. Shall we wind up?
Yes, we can conclude it. And thank you everyone for getting present. And we can conclude the session for today.
Thank you.
Thank you
Thank
very much.
you, speakers. Yes, thank you, speakers, Professor Schwartz, and all the other speakers and
Thank
our
you, Dr.
respective
P.
chairpersons. This was a very wonderful session, an exceptional session where we discussed all the diabetes technologies that are available, especially during this COVID times. So thank you so much, and thank you, Benji sir, and the DICON team for this show. Thank you so much.
Thank you.
Bye.
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 Professor Peter will connect with OnePro.
Very good. Thank you very much. This is very good.
Thank you. Thank you.
Thank you.
Thank
Thank
you.
you. Bye. Bye.
Bye.
One world,
Bye.
one world, one disease, one world, one disease, one fight,
Exactly.
one pro.
One Pro, yes, exactly. Thank you very much.
Thank you. Thank you. Bye.
So here we are moving for the next session. Next session, our workshop on lifestyle. And for this session, would like to invite our reporter, Dr. Meet Shah. Dr. Meet, over to you.
Yes, sir. Thank you, Dharmendra, sir. So we have a wonderful sessions going on, and now we are moving towards workshop, that is lifestyle management workshop, living with diabetes. And in this session, we will be having a lot of international speakers with us. For this session, I welcome the two chairpersons, Dr. Anil Kulshrestha from Ahmedabad and Dr. Sandeep Desai from Valsad. I welcome both the chairpersons.
Thank you, Dr. Meet. Dr. Anil Bhai, would you start? I think your mic is muted.
Muted.
Yeah.
Very good evening.
Good evening.
Good evening, everyone. We are thankful for DICOM team to give us this opportunity. It's a great pleasure to have this session. It's a very important session, lifestyle management workshop, living with diabetes. As we know that diabetes is a lifestyle disease. So until and unless we take some lifestyle measurements to improve our lifestyle, we cannot control diabetes. It cannot be controlled by drugs or diet. So this workshop is very well needed. And I'm very proud that this workshop, and very happy that this workshop, we have all female, all women speakers. So it's a great pleasure to welcome all of them. So let us start with the first lecture. So we have Dr. Tazania Milanakovic. I hope I am pronouncing it properly. She is a professor of internal medicine at the University of St. Cyril and Methodius Medical Faculty in Skopje. She works at a clinical of endocrinology, diabetic and metabolic disease. She has established the Department of Education of People with Diabetes and department ever since. She obtained specialty in internal medicine 1991, PhD in medical science and in endocrinology 2004. She was in education and training in UK. Professor has published and authorized more than 100 scientific articles and international journals, and has been principal investigator and co-investigator, projects of which 11 international, including GCP training. She is author of 2 monographs and 5 book chapters. And she's a member of Executive Committee of Diabetic Education Study Group, DSG. She's a president of Macedonia Diabetes Association since 2013. So I invite Dr. Tazania to start her deliberation.
Dear chairs, thank you so much for your kind invitation. I'm really honored to be again with you, with my dear Indian friends. Thank you to organizing committee and also to Dr. Banshi Sabo for this invitation. I'm really happy to be today with you and to share, I think, so very important topic on diet, and what is the major tips that clinical practitioners should know about diabetes diet. So the nutrition therapy is one of the main principles of the treatment of diabetes. And these are the recommendations for the purposes of this therapy that been recently published. And the main goal of these recommendations is to promote and support the healthful eating pattern among patients, to emphasize a variety of nutrient dense food in appropriate portion size in order to improve overall health and specifically to improve metabolic control and HbA1c, the blood pressure and cholesterol level or lipid levels. So these goals are quite different for individuals, and these goals are based on individuals' age, duration of diabetes, the healthy history, and other present health conditions. And in addition, the healthy nutrition is very important for patients with diabetes to achieve and to maintain their body weight and to delay or prevent diabetes complications. So nutrition treatment must be individualized to address individual nutrition needs. They're based on personal and cultural preferences of different patients, their health knowledge and skills of individuals, and they should be able to assess the healthful food choices, their willingness and ability to make behavioral changes, as well to recognize some barriers they may have during these changes they must made in their life. So in order to maintain the pleasure of eating, the eating patterns has to provide a positive message about food choices, while limiting food choices should be suggested only when it is indicated by some scientific evidence. So in order to propose this recommendation, the published results on the effectiveness of several types of dietary approaches, such as Mediterranean diet, vegetarian or vegan diet, low-fat diet, very low-fat, low-carb, very low-carb, DASH, and paleo diet, have been analyzed. And what is common for all these approaches or recommendations is that they must emphasize what is the importance of non-starchy vegetables. Then it is also important to minimize added sugars and refined grains, and to choose whole foods over highly processed foods to the extent that is possible. So of course, the reducing overall carbohydrate intake has demonstrated the most beneficial evidence for improving glycemia and metabolic control in people with diabetes. So all of these following dietary approaches actually are associated with weight loss, but only if they can reduce the dietary energy that people are taking. So there are only two effective types of energy restriction, no matter what is the dietary approach. This is first the lower calorie intake or increased energy consumptions with realized energy deficit. So this is the main important way how patients can lose their weight, no matter what dietary approach they will choose to be their preferred way of nutrition. So there is no strict dietary recommendations, but only restriction in energy and choosing healthy food for nutrition, and of course a higher level of physical activity in order to lose some some calories during this physical activity. So this is the plate for people with diabetes, or how the nutrition in people with diabetes should be. And of course, this marked food here, it is the only food that is the main regulator of postprandial glucose, and the people with diabetes should be very careful when they are choosing food that contains carbohydrates. There is a couple of tips that is very important for healthcare professionals and how they can teach their patients what is the main importance in their nutrition. The diabetic diet plan is focused on a healthy diet that can control blood glucose and also prevent diabetic complications. There is no specific diabetic meal plan, and this plan must be developed to meet the special needs like individual food likes of each patient, their daily schedule, the medication they used. And actually, what is the healthy diet includes, it's a variety of foods from all food groups with no specific percentage, but still low. The food should be low in fat content, moderate in protein content, then high in carbohydrates, but not all of them. More carbohydrates like beans, vegetables, and grains. And of course, the diet should be consistent to deal with diabetics. They should eat approximately the same amount of calories every day, then to eat meal and snacks approximately at the same time, to spread meals and snacks throughout the day, never to skip meals, and of course, always to watch for a portion size. So this is in a picture what is the good and not so good for nutrition of people with diabetes. Of course, always less sugar and salt, more fish, more cereals, but slowly absorbed carbohydrates, regular meals, and of course enough liquids. I would like to represent what are the three main pillars which are the most important for healthy nutrition in people with diabetes. Then first, it's a healthy diet or dietary approach, then portion size, and finally food label. So what is a healthy diet? Healthy diet, it means at least 5 fruits and vegetable servings per day, and at least 6 grain products servings per day. The low-fat diary, 2 servings per day, 2 to 3 servings weekly oily fish, limited servings of lean meat or poultry, and minimal but right choice of healthy fat. And we are speaking what is the healthy choice of fat. We can clearly see at this picture, which shows what is the relation between type of fats and mortality in people in general. So we can see that those who are consuming the most polyunsaturated fat, the risk for mortality is lower than monounsaturated, than saturated fat. And what is very well known, that trans fats are related to the highest rate of mortality. Why is it like this? Because the trans fatty acids, the trans fats, they are mainly in cakes, in cookies, in pies, etc. It is very well known that they can rise the LDL cholesterol, they can lower HDL cholesterol, and intakes of trans fats is strong prediction for early development of cardiovascular diseases, especially in people with diabetes. What is the good source of fats? Of course, these are essential fatty acids, specifically omega-6. And it is also shown that the higher intake of omega-6 is associated with reduced risk for cardiovascular diseases. And this meta-analysis shows that each 5% increase in energy from polyunsaturated omega-6 in place of saturated fats can reduce the risk for coronary heart disease up to 10%. It is the same with omega-3 fatty acids, and it is shown that there is an inverse association with intake of these fats with heart failure, and also they can lower triglycerides. And the Predimed study shows that they are not beneficial only for cardiovascular disease, but only 2 weekly servings of oily fish can decrease even the risk of sight-threatening diabetes retinopathy. And what is the Predimed study that shows what is the benefit of real diet or Mediterranean diet? It was a multi-center trial that was conducted in Spain. It was enrolled more than 7,000 participants who were at high cardiovascular risk, but with no cardiovascular disease at the moment of enrollment. And they were randomized to 3 groups: the Mediterranean diet supplemented with extra virgin olive oil. The next was with nuts. And the third group was like a control diet. The people was suggested to take a low-fat diet, and it was like a control. So the primary endpoint was major cardiovascular events. And after 4.8 years, the trial was stopped, and it was shown that there was a significant lower incidence of acute myocardial infarction, stroke, or death from cardiovascular causes in both groups with Mediterranean diet in comparison to control. But very soon after publishing of this study, there were identified some protocol deviation of this, including enrollment of household members without randomization, and assignment to a study group without randomization of some participants at one of 11 study sites, and also apparent inconsistent use of randomization tables at another site. And that's why these patients was excluded from the trial. They were withdrawn from the analysis. And there was a new revised report that was published 2 years ago, also in New England Journal of Medicine. This is interim analysis, and we can show in this here panel A that the results are almost the same, that the incidence of the primary endpoint, so the acute myocardial infarction, stroke, and death from cardiovascular causes, is lower in both group with Mediterranean diet in comparison to control diet. And also in this panel, we can see that total mortality is lower in group with Mediterranean diet and extra olive oil. So after the correction of these results, we can see that really Mediterranean diet is related to better prognosis regarding cardiovascular disease in patients with diabetes. This is another part of this interim analysis. This is a hazard ratio for the primary endpoint in each Mediterranean diet group as compared to control. And we can see that all of them are in favor of Mediterranean diet group. So the second pillar of healthy nutrition is portion control. And we know that the portion size of many different foods have increased significantly over these 2 decades, even and previous. And nowadays there is a larger portion size that are offering in restaurants, in selling machines, in packages, and people are prone actually to different size, different kinds of food, but the portion size is larger than it was before. So here we can see that this is happening not just 2 maybe decades, maybe even before, and there is a huge increase in portion size, especially these 2 decades, and this means that there is a larger or calorie intakes which leads, of course, to obesity and then to high risk for developing type 2 diabetes in population. In this study, we can see what is the percentage difference in average portion size between 1995 and 2011 by food category. So some food categories like pizza, cake, ice cream, sausages, processed meat, cereal bars, there is a significant increase in portion size, which means higher calorie intake and, of course, obesity and diabetes. So the question that we want to know the answer is: does the portion size really matters? So of course that they do not matter, but only if a person is able to choose an appropriate serving size rather than to eat the whole portion that is served in front of him, or to eat the fewer calories which are dispensed in a couple of meals as snacks through the day. But the question remains: do the people intuitively can assess what is the appropriate serving size, and do they actually eat only appropriate servings, or they are eating the whole food that they are offered with? So the answer is that in a couple of research, it was shown in a couple of articles that people often eat the amount of food that is in front of them, and they have really difficulties. They cannot always assess whether this is appropriate amount of food, and very often that they are eating more than appropriate size for them, and that's why they are gaining a lot of weight. So we also in my country published a couple of years ago these articles. We were trying to find what is the reason for high percentage of obese, overweight people in Macedonia the recent couple of decades ago, and why there's a so huge percent of people with diabetes. And we find out that there was a significant change in calorie intake among Macedonian population these last 2 decades, and these calorie intakes increase about 750 calories per person. Just there is this number of 53% of population overweight and 20% obese in 2014, and the diabetes incidence near to 11%. Also, this Cochrane analysis review that shows that people consume actually more food or non-alcoholic drinks when they are offered with larger size portion. So the size of this suggests that if we can, or we are able to eliminate these larger portions from the diet, then the people can reduce their calorie intake and, of course, to lose weight and to reduce their risk for diabetes. There is also another Holland's study with same estimation that is lined with previous ones, which shows that the portion size is really responsible for this higher calorie intake and, of course, higher percentage and diabetes. And finally, the food labels, like a third pillar for healthy nutrition. We also know that the food labels are very, very useful tool that can help patients with diabetes to assess the nutrition value of different kind of food. So in the same way, they can also get some very useful information in the amount of carbohydrate choices, but also in the amount of calories and other important and cholesterol. And that's why it is very important to recommend to all our patients to be aware that it is very important to read the food eating and what the nutrients they are taking with their meals. As the main 10 tips for diabetes nutrition that we must follow to our patients, that they must choose healthier carbohydrates, to eat less salt and less red and processed meat, to eat more fruit and vegetables, and to choose healthier fats, to cut down on added sugar, always to be smart with snacks, not too many snacks, to drink alcohol in moderation. They shouldn't bother with so-called diabetic food, but just healthy food. And of course, to take enough minerals and vitamins from foods. So if I can conclude, now there is no specific diet for diabetes. There is a dietary approach that we can suggest to our patients. And the main advice is that they must replace saturated fat with unsaturated fat to reduce the heart disease and mortality risk, then to limit red and processed meat and to replace them with healthy protein sources, then to eat a lot of fruits, vegetables, legumes, nuts, whole grains, to reduce consumptions of refined grains and sugar, because a healthy diet and lifestyle which is healthy can add more years to life, and of course more life to their years. Thank you for listening.
Thank you, Professor Tanya, for giving this wonderful presentation on diet. Actually, it is the most controversial and most discussed topic. What are your opinion? I mean, do you think that, what about packaged food? And your opinion on whether government should regulate this all labeling and all that, and it should be compulsory to reduce the
What kind
packaged
of
packaged
sorry,
food.
package?
Packaged food, which is freely available in supermarket, and which is usually it does have labels, but usually these are high calorie and not nutritious food.
Well, that's why the food label are so important, because the patients, when they are buying packaged food, if they are properly educated, they can actually see what they are eating. And it is very important to know that they must avoid some kind of fats, some kind of a lot of salt, then refined sugars. And if they are properly educated, they can read from the labels. And of course that they should avoid the packaged food, because it is not always the good approach to food. But they will eat, but they should know what are the ingredients in that packaged food. And that's why the food labels are so important.
What is your opinion, whether government should regulate it, or because it's very difficult?
What government?
Yeah,
what?
Government should regulate the portion size and caloric value. Like in many countries, they have asked them to reduce the salt in quantity in the food.
Of course, they must reduce the salt. That you're
not
asking?
only salt, calorie and portion size.
Yes, the calorie and the portion size. They can eat whatever they want, but if the portion size is small, of course the calorie intake will be limited. Even if they eat the healthy food as fruit, but if they eat large portions, they will get a lot of carbohydrates and their blood sugar will not be okay. And of course, they will eat a lot of calories, because only one apple is about 70-80 calories, which is almost the same like one slice of bread. So they should be aware. That's why of the nutrition.
Sandeep bhai?
Hello.
Sandeep bhai, please.
Yeah.
Yeah.
So probably
Any
there was some
questions?
signal loss.
Any
And
questions?
our next speaker, it was a very good talk. I had one question. One is doctor mentioned about rice, that from carbohydrate, rice is one of a healthy choice. So probably we in India eat a lot of rice all over India. Rice is the staple diet. In most our lunch part consists of rice.
A
So
little
somehow,
break in my internet connection. I'm sorry.
yeah.
So this,
Dr. Tajana, there is
yes,
one question from my side. You
yes.
mentioned in your talk about carbohydrates and healthy carbohydrate. Rice is one of the healthy carbohydrate. Probably we have that notion all over India that rice is not good for diabetes patient. So can you
No, there is an
elaborate on that
integral
part?
rice, not the white one, but the integral rice, and of course in moderate quantity, it can be a good source of carbohydrates because there is a complex carbohydrate in rice, and if they do not have a large portion, and if it is integral rice, it can be very useful for that. But not that, and we in Macedonia have the similar rice as in India. It's a white one. Of course, if you're eating a big portion, it is a it's a huge number of carbohydrates and calories as well.
Right. I just wanted
So
to
everything
mention.
is moderation, and that's why these three pillars. It must be a healthy nutrition, but in moderate amount, and of course with information. What is that food that we are eating? They should know what kind of food they are eating.
Right. I think that sums up the session. Should we move on to the next session? Our next speaker is already there. And it is challenges in diabetes care in low resourceful country. And Dr. Ashad Shiruhana, she is a CEO of Diabetes Study of Maldives, which is the only NGO dedicated to diabetes awareness and care in the country. And she's working in the sector for more than 20 years. And currently she is the president of Maldives NCD Alliance and member of the advisory committee, Faculty of Health Science of Maldives National University. Dr. Ashad, the mic is, the whole dais is yours.
Good evening. I hope you can hear my voice.
Yeah.
Yes, we can.
Perfect.
Yeah.
Perfect.
Please go ahead.
Yeah, I have been asked to talk about how we manage diabetes care in a low resourceful country. I'll try to share my screen. Can you see my screen? Are you able to see my screen?
Yeah, you.
I have been looking and hearing the previous speakers, and I have been seeing a lot of informative sessions about the technologies, about the latest technology, CGMs and all. My presentation might be a little bit different from others because
where you conceptualize that the body's susceptibility to lifestyle diseases was programmed intrauterinely.
Hi.
So how exactly is this fetal origin of disease hypothesis? Well,
hello.
It states that susceptibility to cardiovascular disease.
Yes, please, doctor, go ahead.
Okay. Yeah. So I will just try to talk about how our country is and how, as an NGO working in the Maldives, how we try to provide the necessary care for the diabetes patients and also run the awareness and screening programs in the country. I'll just try to introduce Maldives. I'm sure almost everyone here knows about Maldives, but I will just try to introduce how we are. So we are a country with 20 atolls and a number of atolls, islands in each of the atolls. So at present, there are about 188 inhabited islands in these 20 atolls. Coming to our health system, our health system is divided into different tiers, where we have 5 tertiary hospitals, 4 regional hospitals, 14 atoll hospitals, and 172 health centers. Moving on, I'll just like to highlight to you how our health system is. As you can see here, this is Male, which is the capital of the country, and almost all the tertiary hospitals are here in the capital. There are 2 tertiary hospitals which were declared as tertiary hospitals, which has been upgraded, which was done since the COVID. So when the COVID pandemic started, we had only the tertiary hospitals available were only in the capital of the country, and the capital of the country was in a total lockdown for around 2.5 months. So moving on to our role, what is the role of NGOs? So there are many NGOs and CSOs working at the national and regional levels, and the NGOs are really formed to fill the gap identified within the government. Like these NGOs offer services at different levels. Some include awareness programs, prevention programs, and there are some NGOs who offer patient care to some level as well. Moving on to us, we are the Diabetes Society of Maldives. We were formed in 2002, and there was an awareness of a need to educate the public on diabetes, to educate the public on about the prevention of diabetes, importance of early diagnosis. And then also there was a very much higher need for patient care, to improve the care of the patients throughout the country, to have someone to act as a center of information on diabetes in the country. So Diabetes Society was formed in 2000 because of this. We have been working in the country for almost 20 years, and we have achieved a lot during these years. So coming to us, we try to offer different services in different aspects of diabetes within the country. Like we have a clinic which is based in the capital of the country, and this is the only clinic especially for diabetes patients, and it's a free clinic. We do a lot of screening awareness programs within the atolls as well. We do a training of diabetes educators. We have a Save a Diabetic project. We also try to offer psychological support for patients, and also we run a camp for youth with diabetes. Going on to our screening and awareness programs, we started screening and awareness programs in 2002, and we do a lot of programs in the islands, in the atolls, in workplaces, in the offices, and we other than blood sugar, we do calculate the high risk level through anthropometric measures, and also behavioral risk and risk stratification as well. And I just wanted to point out that very frequently in our screening programs, new cases of diabetes and other NCDs, including high blood pressure, are identified in the screening programs in these health camps. Looking at a number of screened population starting from 2004, we have screened about 47,785 people in the screening programs. And looking at some data from these screening programs, you can see that the prevalence of type 2 diabetes is like 8.1% of the population. We have heart disease as 3.1, hypertension is 14.9. But looking at the obesity level, 13.5, but we have a very high overweight level of 67.7. 67% of the population are identified as overweight. And then when we do the high risk score, we have a 62.5% of the population that we have screened are identified as high risk for diabetes, which without an intervention might go on to be diabetic within the next 5 to 10 years. So looking at, I will be using this chart of the Maldives as because this we have a very hard time like explaining to people how our country is. So this is how our country is. So I will be using this chart a lot. So looking at the prevalence, there are very high prevalence in different areas of the country and very low prevalence in some areas of the country. And then I would like to distinguish the fact here that according to our screening programs, like we do not really see a higher prevalence in like maybe the urban or rural as such, but maybe because of the family history and such, there are higher prevalence in some parts of the country. Because as I have mentioned before, our islands are scattered all over all over, and there might be around 500 or 1,000 persons in one island, and there might be around 5,000 persons in one island, depending on where the island is located. So it was a very big challenge for us. We being situated in the capital, our NGO being situated in the capital, and our clinic being situated in the capital, it was a very big challenge for us to provide the necessary care, the education, and also we came up with a project called Project 200 Islands. When we started this project, there were 200 islands where people were living, but now it has gone down to around 188. So the challenges were very obvious. There were a lot of logistic challenges. There was access to quality. There was no access to quality healthcare in the context of diabetes. There was no awareness sessions. There were no patient care available. So we came up with a project called Project 200 Islands, which was funded by the World Diabetes Foundation, where we try to educate one educator per island, so that there would be one person who would be able to take care of the diabetic population, or who would be allies with us in each of the islands. So we started this project in September 2009, and it took us around 2.5 years to finish this project. And by the end of this project, there was one educator in each island of the country. So these educators play a very important role in they provide the necessary education. They try to provide the management of the patient and care in the islands, and also they form a very important link between the islands and us at the capital. So I would go on to our clinic. So we have a free clinic in the capital of the country, where we provide the diabetes, we do the complications, we do the investigations, we give advice on diet and exercise, we do mental health counseling sessions as well, and then we also do consultations if it is required. So at the moment in our clinic, we have a total of 1,919 people registered, and our average patient is like 10 people per day. We have 136 type 1 registered patients, and then I would just like to highlight the fact that we during the COVID we also had a lot of problems, as we were located in the capital, and many of the patients were in the island. So we also had to do a lot of online consultations, had to rely on technology a lot, did a lot of online consultations as well. But the problem with the major problem that we faced was the insulin distribution, because of the geographical locations and because of the capital was in lockdown for 2.5 months, there was no way that the patients were able to travel to the capital to get the necessary insulins that were needed. And we were getting calls saying that, oh, we have only 1 or 2 days of insulin left. So we had to work really hard to provide the necessary insulins needed for the patients to stay alive. And just like to highlight that we had to come an agreement with the multinational defense force, where they were doing emergency transportation to the islands to provide the emergency needs, and we had an agreement with them, and so we were able to provide the necessary insulins and the testing kits needed for the patients in the islands. Just wanted, as I was talking about the insulin distributions, these are how the type 1s are distributed around the country. As you can see, there are some atolls where there is only 1 patient. So it's very difficult for the government to maintain the logistics to provide the insulins, to keep the insulins, and to make it available in the island. So mostly the insulins are available in the capital, and during normal circumstances, the patients or a relative of the patient will will get the insulin from the capital and send it to the islands. But this became a really big problem during the COVID-19 lockdowns, as there were so many patients in the islands who were really finding it difficult to get the insulins. But we were really happy that we had an agreement with the Ministry of National Defense Force to provide the insulins for the people, for the type 1s in the islands. I just wanted, like we have been talking about insulin, CGMs and all that. I just wanted to just take you through about how insulin came to us and how. So this in 2004, we received a donation from Insulin for Life as an aid after the tsunami, which hit the Southeast Asia region in 2004. And I would like to highlight that this is the 16th year anniversary today. So 26th December is the day that the tsunami hit the Southeast Asia region, and it hit more, and it devastated the islands in the Maldives a lot. So then we got an aid from the Insulin for Life, where we received insulin pen, and this was the first introduction of insulin pens to the Maldives. So these were donated to the type 1 across the country. Since we were formed in 2004, we were not really focused on type 1 diabetes. Mostly our patients were type 2, and we really didn't have a lot of ideas about type 1s and how many type 1s were living in the country. So then after the 2004 donations, we were getting periodic donations for Insulin for Life from for Life. So here are some pictures of after the tsunami, where we were able to travel to some of the islands, introduce the insulin pen for some type 1 patients in the islands, visit the health centers and see how many patients were there. And then even in some instances, we had to have an impromptu screening sessions, because there were so many patients, and they have been without days without any blood sugar testing. So this was in 2004 after the tsunami. So after that insulin donations, we founded a program called Save a Diabetic Child program, which was launched in November 2008, and then there were around 32 patients registered under this program. So these were supported by some local companies, Life for a Child and Insulin for Life Australia. So we were trying to, when we started receiving these insulin pens, there were only vials and syringes in the country. And since the Maldives are an island nation and we have to travel a lot in the dhonis and boats and all, it was very difficult for the people to carry the insulin. And so it was really helpful for the type 1 patients with the introduction of the pens. And so we were under this project, we were able to provide the insulin pens and the testing kits which were needed for them to do the necessary testing as well. But even though then most of the insulins are available in the capital as such. So at the moment we have around 136 patients which are being supported under the project. Here we would like to highlight that since 2018, insulin pens and needles are being supported under the Universal Health Scheme in the country, and we were able to advocate to the government on the importance of the insulin pens and for the type 1s on receiving the insulin pens and needles. So now it's supported under the International Universal Health Scheme. We also do Maldives youth camp for the youths living in the country. As I showed you before, there were some type 1 patients. There were only one, in some instances, there are only one patient living in one island. So these patients have never met another person living with type 1 diabetes, and they really have no idea of how if there are other kids or other people who are living with diabetes and how they manage. They are never able to discuss or have a conversation with any other type 1. So we started this 5-day camp targeting youth with diabetes between the ages of 13 to 16. So this provides the young people with diabetes with a unique opportunity to share and learn from others with diabetes. So the primary objective was to provide the children and young people with diabetes with a fun but safe environment that allows them to learn about themselves and their diabetes, to reinforce their current education and promote and further development of management and coping strategies. So they had the opportunity to interact with other young diabetes, and it allowed them, the youth, to feel at ease and accepted in a community where having diabetes is the rule and not the exception. And I just wanted to highlight that in 2014 and 2018, this camp was held as an Maldives International Youth Camp, where young type 1s from Southeast Asia region, other countries including India, participated in our camps as well. So here are some of the pictures. Just wanted to highlight from some of the camps that we held in different years. So I just heard about the insulin pump and the CGM. So the first pump which was introduced to our country was a donation to Diabetes Society of Maldives from the Czech Diabetes Association, which was in 2013. So one of our young leaders, IDF young leaders, received the pump as a donation from the Czech Diabetes Association and in 2013. And she was the only type 1 with pump in the country for some time. We have a lot of faculty from India in our youth camps as well, talking about different topics as well. So in 2016, Dr. Jyoti Dev introduced a lot of latest technologies in diabetes in our youth camp, including the CGM and the pump as well. So we started insulin pump therapy for 10 youths with type 1 diabetes in September 2017, which was a really big milestone for in our endeavors to improve the life of people with diabetes. And I would just like to thankfully highlight this. These pumps were donations from Jyoti Dev's Diabetes and Research Center as part of their programs. And we were able to come up with an agreement with the National Social Protection Authority of Maldives to provide these 10 young people the necessary pump accessories free of charge under an MOU with the Diabetes Society of Maldives, where we report to the National Social Protection Agency about how their quality of life is being improved with the insulin pump therapy. Just wanted to highlight here a video.
Hi, my name is Ari. I have been a type 1 diabetic for 15 years. Getting on insulin pump next best thing that can happen to me. The first being my further results. For over half of my life, I have taken multiple shots every day just to survive. And now, it's so much pain-free. Thank you for this amazing device. Thank you.
My name is Fatma Juzan Muhammad. I am 21 years old, and it's been 9 years since I've been diagnosed as a type 1. Currently, I'm working as a preschool teacher in Gazi School. I started using the pump last year, that is 2017 September, and a lot has changed. Especially my HbA1c has decreased from 14 to 8 within 3 to 4 months.
Hi, I'm Mohammad Jai Shamhood. I have been diabetic for 9 years.
And I am Mariam Nafa, and I have been diabetic for 3 years.
And we are
students of Maldives National University. Before insulin pump, we used to take insulin shots multiple times a day, and it was very painful. And it was also very difficult for us to control our blood sugars then.
And after the pump therapy, we have seen a big change in our life. It has been easier to manage diabetes, to control our blood sugars. Before, we usually sometimes forgot to take insulin. We don't know whether we took the insulin shot or not, and there's no way we can check whether we took the shot. But after the pump, we can check when our last dose was given. So if the dose was not given, we can set the dose and give at that time. It has made our life much easier to live with diabetes.
Hi, I'm Nazia. It's been 5 years since the diagnosis, and last year I got the chance to start insulin pump therapy. Surprisingly, I could go about with my day-to-day activities with the pump. Thank you.
So these are the kinds of videos that we use to advocate for the government on the importance of the latest technologies, and to make it available for the type 1s living with diabetes. At present, we are advocating with the government, with the policy makers, to establish a national registry of all the patients living in the country. We are also advocating to establish a national diabetes guideline. Unfortunately, we still don't have a national diabetes guideline, and it becomes very difficult, especially when the treatment varies from island to island and hospital to hospital, since there are no national diabetes guidelines. And also we are working to ensure the availability, and even if there's availability in the country, it's only available when it's only available in the capital of the country. There's no accessibility of insulin for the type 1 patients living in the island. So we are working with the policy makers and advocating for the accessibility of insulin for all type 1 patients living in the country, and also to provide the testing kits to type 1 patients living in the country. So I hope that you got a little bit of information how we try to manage the diabetes, and to provide the necessary education, and to do the prevention in a country where the geographical locations of the islands make it a very difficult task to provide the necessary care and education. Thank you.
Thank you, Dr. Asad, for giving us insight of Maldives diabetic control. And kudos to your NGO. You are doing a great work, and please continue doing such. Dr. Sandeep Bhai?
Yeah, I think it was. I think Maldives is lucky because just I was googling it and it has 5 lakh population, and I am living in a small district in India, a very small district. You even don't know Valsad, and it has a 5 lakh population. So you have that advantage of a small population getting so much benefit, and almost 7.5% of your patients are on insulin pump out of that 136.
Yeah.
So you are very lucky, I guess. You're very lucky.
Can I ask a question? Out of 20 island, you have few places where the prevalence is very high, 12.1% or something like that.
In the 20, out of the 228 atolls, right? Yeah.
So, did you have any epidemiological study or something like that to know?
Unfortunately, we haven't been able to do any, and we would like to do an epidemiological study.
Because it's very important.
Yeah.
So, I think Dr. Riana want to ask something.
Yes.
Please go ahead.
Did you hear me?
Yeah, please go ahead.
I want to use my position as Vice President IDF and say big thanks to your job, to your team, that you give a lot of opportunity, unique opportunity for your patient, for people with diabetes, and improve them life. Thank you so much for you, for your team, for your people. And say hello to your youth leader, which I know. Thank you.
So I think now the next session will be taken by Dr. Irana from Ukraine, and she will be talking about art of communication, key to successful DSME. So let me introduce her. I think they can put a slide to her introduction. Yeah, Dr. Irana is board member, International Diabetic Federation Europe Regional 2015 to 2019. She is a PhD of pharmacy, is associated professor at the National Medical Academy of Postgraduate Education, Ministry of Health of Ukraine, and she is supervisor of international PhD student. Her research interests are pharmaceutical care of people with diabetes, reform of healthcare, the development technology of new complex action medicine, medical films, gel, cream for treatment, chronic wounds and diabetic foot wounds, for dentistry, therapeutic education of people with NCD, ethical aspect and rights of patient, including in clinical trial. She is responsible editor of Scientific and Pharmaceutical Journal, editor of Diabetes, and just a second. She has 155 publications, 8 patient, 6 books. Also, she's a co-author of publication of IDF Europe 2017. She's international expert in diabetes. She's a member of National Diabetic Council, member of multidisciplinary working group in draft medical technology document for standardization of medical care in diabetes type 1 and 2, Ministry of Health of Ukraine, member of Public Council of Ministry of Health of Ukraine, Deputy Chairman of Public Council of State Administration of Ukraine on medical products. In addition, she became an active member of a strong team of the Professional Ukraine Diabetic Federation. I think this list can go on. I will request her to start a deliberation. You are very accomplished career, so please enlighten us.
Yeah, thank you so much for too much information about me. And I'm very happy to be attended to this. I just only share my screen. Yeah, I hope you see. I'm very happy to be attend to this great conference. Thank you very much to Professor Banshi Sabo for invitation me. I'm very happy to be useful for our diabetes community. especially for Indian, because Indian in my heart from childhood. I think our session is very attractive because only in this session includes very attractive women. In this case, our session will be very successful. I joke, of course. And I want to start because we very close great data like Christmas. I want to say to our audience, Merry Christmas and Happy New Year. And I hope and I wish for next year we will be more successful and we have no problem as we know. And today we will speak about very important subject at communication because we very often speak about knowledge, about really knowledge, professional knowledge, but without communication we cannot deliver a good quality treatment. Look, Joint Commission reported that communication failure rather than any lack of technical skills of understanding was at the root of over 70 of serious adverse health outcomes in hospital. 2 out of 3 patients leaving the hospital don't know their diagnosis. In 60% of cases, patients walk away from a doctor visit, not understanding what they are supported to do, instruction for medication and lifestyle change. People with diabetes internalize messages from many resources, the media, from people around them, like patients, friends, and family, but healthcare provider, the most important person who deliver treatment and information for people with diabetes. But unfortunately, doctors are not both with excellent communication skills like every person. In this case, but doctor unique position in respect and power, and they must learn about communication, most very important thing for them. Effective doctor-patient communication through the motivation, extensive reassurance and support, increase job satisfaction, both of them, reinforce patient self-confidence, increase outcomes, and decrease cost of treatment. If you look on this big slide, this is a very big complex patient-doctor communication. And despite communication skill training in medical schools, doctors continue to demonstrate poor patient-doctor communication skills, which show some research. Of course, we have a lot of barriers to good communication in the doctor-patient relationship. It's international, linguistic, physical, culture, organizations, time management. And also, this is new things resisted by patients. Today, patients have recognized that they are not passive recipients and are able to resist the power and expert authority that society grants doctors. They can implicitly and explicitly resist the monologue of information transfer from doctor, but actively reconstructing, expect information to assert their own perspective. Important but overlooked communication lapses, which show some research that have 4 most important lapses. This is not non-verbal, it's eye contact, facial expression, paralanguage, verbal, active listening, inappropriate choice of words, poor attitude, lack of respect and empathy, and contact, poor quantity and quality of information provided. But it is not about our audience. Training doctors should include non-verbal paralinguistic elements. I take only two, like phonation on kinetic, phonetation, sorry. Tempo, temperage, speech volume, pause, pillars, for example, melodic speech, and kinetic, gestures, posture, facial expression of the speaker. You can see this big book about this new book about this paralinguistic how deliver this information, use these skills, and some university use simulation-based communication model for training doctor, and also we must highlight negative emotion of doctors as influence their communication pattern. I promote very often communication skills for healthcare professionals. So in addition, it's new books. Please look this link. You can donate free this very interesting book and very useful for you because it's a lot of information about diabetes care. And we can say like general guidelines to follow with patients. Show respect and compassion. Practice unconditional positive regards. Show concern and interest. Practice objectivity and enhance awareness and observation skills. Tips for better communication with a patient. Interesting. I find this is like 3 out of 4 doctors don't introduce themselves to the patient. Speak, not use this medical term. Don't say hypertension, say high blood pressure. Don't say hyperlipidemia, say high cholesterol. And check if your patient understood you, but don't ask, do you understand? Of course, patients will respond, yes, but I'm not sure about this. And but please ask, repeat, what do you say? Be adaptable, slow down and adapt to this situation, and tend to other needs, questions of your patient. Show empathy. Gain context for what's going on the patient life. Be awareness about really life of your patient. Just be honest. Patient want the truth. Don't beat around the bush. This is also was interesting research that show the patients say it's very important to provide to communicate about chronic disease management by making personalized recommendation based on information that is specific to patient and their individual needs, helping patients understand their current and targets health methods, sending medication refill, and pick up reminders by technology. Deliver online service of check-in to help monitor disease, identify health risks, and manage chronic conditions. And I want to highlight the 4 critical times to provide and modify diabetes management education and support service. We have like 4. At diagnosis, like first time, then annually and when not meeting treatment target, when complicating factor develop, and when transition in life and care occur. Steps in the process of diabetes self-management education reflect cycling and ongoing in process, monitoring and evaluation, assessment, goal setting, planning, implementation, and so on again. This is unfortunately this disease forever now. Model of patient education, we use different model, like paternalistic model, I decide for you everything, deliberative model. In addition, I tell you my preference. Informative model, I give you facts, and interpretative model, I give you fact and help you to find your preference. I think it's we must use all of models, combination of these models, and of course every model use little bit another communication skills. Language is powerful, and words have the power to elevate and destroy. For people with diabetes, language has an impact on motivation, behavior, and outcomes. For decades, a substantial amount of the language around diabetes has been focused on negative outcomes. I remember that like 15 years, oh, you have diabetes, mama, yeah, this is catastrophe. But now, you know, we have a lot of good plus things which we can manage diabetes now. And this is time for the language around diabetes must change. The International Diabetes Federation published a language philosophy because they believe that there is a responsibility to set an example about appropriate language to others. And this also, we are thinking that we can change our words. For example, if you speak about control, we very often use blood glucose level, blood glucose target, glycemic target, glycemic stability, glycemic variability now you must use. But for people focus on natural words and philosophy biology, define what good control means in factual terms and use that instead. Guideline principle for communication with and about people with diabetes. You know, we have many factors and variables. Stigma that has historically been attached to diagnosis of diabetes can contribute to stress and feeling of shame and judgment. Every member of the healthcare team can serve people with diabetes more effectively through a respectful, inclusive, and person-centered approach. Person first. This is also a new document, Language Matter, which development by National Health System in England. That you can find practical advice how to use of incorrect and stigmatizing language can lead to further discrimination in people living with diabetes, and you can find a good example how to change this language. But we must remember our principle on this. Recognize that some words, phrases, and description are potentially problematic, whatever the intention of the user. Use language that free from unjudged or negative components. Avoid language with attribute responsibility or blame to a person for development of their diabetes or its consequences. Avoid language that infers generalization, stereotypes, one individual with previous experience and other or a similar background or in similar situation, every person, individual. Use of development and empathic language style, which speaks to experiential and person point of view of other condition rather than assume. This is a picture from my experience, practical experience as educator of people with diabetes. I like this because this will give feedback, great feedback, and if you find like if you see good results, and some people lost weight, some people can manage them diabetes. This is extremely good feedback and motivation for you. But you must use a lot different model and also control control knowledge. And of course, what I want to show that we must use the different methodology, different. For example, this is you know about this about MAP. But this is not only map that we can use for different type of subjects. We must make combination of this. And it's very important training for doctors. And this is one research, this new research, the study designed a type of learning software to train the interns to advance their communication skills. And they show that after this computer training, they more respectful to patient and show empathetic communication behavior. It's great that the doctor-patient communication software may help the doctor know more about communication skills. And another interesting research that the improved behavior may lapse over time. In this case, we must do this regularly and check our patient, also listen from them. In our session was before about technology. Digital revolution will have big impact on our physical interaction with patients. Are we ready for this? Look in this big complex include for this communication in this health era, and especially in diabetes, because now advancements in healthcare delivery technology, smartphone, telemedicine, mHealth, and so on, in significant opportunity to achieve better efficiency in diabetes care and increase patient involvement in diabetes self-management. Are we ready for this? I'm very happy to listen that Germany, Professor Peters promote them course. It's great opportunity and free course for improve our skills. But we also must remember about 6 factors of communication risk by patient safety and quality health care. This could be culture, according to some culture beliefs. Another social economic factors can be risk, because many doctors think that patients from a low social economic status desire less information. This is also could be risk, maybe it's not right. Literacy factor. Patients with English as second language may not be able to understand writing instruction. Time, hectic schedule produce fatigue. Many doctors have a lot of patients and have not enough time for effective communication. And unfortunately, I must say this, gender factors. Male physicians are more likely to overestimate their communication skills. And this is also a risk because they expect another thing. And a physician will behavioral issues such as tendency to yell. This is negative, and this is also for risk for people. And we must, as I say, if we go to this era, digital era, we must know about this and to have training like digital identify, safety communication, learn and self-development, technical proficiency information, data and media literacy, digital creation, innovation, and scholarship. Sorry. And engine, I would like to promote IDF School of Diabetes. You see the online course is available free until 31 December 2020. So you can find time for register and you can go free. The role of diabetes education. You can find a lot of information in this course. Thank you so much for your attention and Merry Christmas.
Thank you, Dr. Irina, for giving a wonderful presentation. See, communication is required in all form of life. Interpersonal communication or communication between patient and doctor. These are all very important factors and nobody actually talks about it. It is high time that it should be included in the curriculum of medical education, because doctor-patient relationship is the most important relation. Until and unless you have trust of the patient, you won't be able to treat patient or convince him or have a confidence. Dr. Sandeep Bhai, you want to have some say? You have unmuted. Please unmute yourself. Sandeep Bhai.
Sorry. So it was excellent presentation. I think it is a need of the hour because diabetes being a chronic disease, we all need to communicate properly. And we in our National Diabetes Education Program, in which I am one of the certified diabetes educator, what we educate when we train the educators, this is one module specifically that how to deal with a difficult patient, how to communicate with them. It is one of the most important part because that 2 or 3 minutes which the doctor is giving, and it helps to build up the confidence. This should be one of the curriculum for everyone, for all doctors. And I always tell that it is not for the doctor and the patient, it is for your life also. Whenever you are with your partner or with your family, the art of communication is very important, because how you see their eyes, how you listen to them, rather than looking at the mobile when you are talking, so that is all. It's a important part of everyone's life.
Yes, and I agree with you. And this is, I check many programs for doctors, for educator. Yes, we speak about pedagogic methods. We know about this, but not many information about communication skill. This is also must be professional delivery, and this is only professional delivery. This information must be.
Right. Any questions? Anything else? Yeah, we are running short of time. We should go to the next presentation, which is on women leadership in diabetes health orientation. And Miss Enak Mawasi, she's already there from Israel.
Yes.
Hello, Enak. And
hello.
She has a lot of certificates and courses, and course fundraising and public relations related to organization Nazareth, and managing anger and feelings, Moffat Institute, organizational behavior effectiveness, Institute of Technology, Baka, and workshop on how to recruit new students for the college. She has a lot of awards also, won the Minister of Science, Culture and Sports praise as an Arab leading journalist in the aspect of writing articles and success stories, and the only Arab individual who won in writing specialized stories in teaching. And she has an outstanding performance at the seminar in teaching internship. And she has initiative women in various fields, speak and write 3 languages, stronger personality, think rationally and study all the options, very good in computer skills, communication skills, hiking, biking, group discussions, organizing cultural events, dependable, dedicated, professional, and she's a down-to-earth lady and have a great sense of humor. Over to you, Enak.
Hi. Good afternoon for everybody. Thank you a lot for participating in this conference. I do appreciate. Shall we start?
Yeah.
Okay, just a minute. I want to have my share screen. How can I back to the Zoom? Okay, let's share screen about. May you help open my presentation, please? Yes, this is my presentation. Do you hear me?
Yes, we can hear you. Please go ahead.
Okay. So my presentation is about women leadership in diabetes health orientation. Please move to the next slide. Can you help, please? Okay. So my name is Ainak Mawasi. I'm from Baka El Garbia. I am Arab Muslim woman, lives in Israel. A health promotion consultant for health ministry, clinics, and health promotive in the Arab Community Association, which is an organization, a representative in international health diabetes conferences in India, in Brussels, in Jordan, in Malta, Cyprus, and so on. Please, next. So I have two aspects, my country and my culture. Israel has various nationalities, religions, languages, and cultures. I'm belonging to Israel as a country and also belonging to a conservative society and Arab traditional culture. That means a health promotion should be suit and match the target group. Hence, the Arab society is considered as a collective, and the doctrine, care, and medical approach are not matched by all means. Since doctors, most of doctors, Arab doctors, learn in Europe and back to their societies to give the care and the nursing. So we have a gap. Next, please. The Arab society in Israel, this is a photo for the Nazareth. Now we are celebrating the Christmas, so Merry Christmas for you all. The Arab population is considered as 20% of the Israel populations. So we are approximately 1 million to 5,000 hundreds from 8 millions. We are Muslims, Christians, Bedouins, and Druze. This is two photos for the Arab population. Where are they? From Jerusalem, which is the biggest place in Israel, and also it's a religious place. And this is the Al Jalil. It's called in English Galilee. Most of the Arab population are in Jalil. So diabetes is considered as a social disease. Why? Because diabetic patients, most of the time be on pressure, social pressure. So they eat the same meal and they are going to the insulin and medicine because it's easier to balance the sugar in their bloods, besides to keep a healthy meal for them. So we share the same meal in Ramadan and in other times. Next, please. Why do we have a social pressure to be accepted in the family, to be accepted in a group, sometimes to be accepted in a school and with our friends? Diabetic patients can't control their meals while others enjoy high-fat and sugary meals. If you look at this picture, this is a typical meal for Arab family, meal in Ramadan on any occasion. If you look, we have a cola, we have juice, we have lots of fats, we have a white bread. So the diabetic face difficulties to control their meal and control themselves to accept and balance their sugar in their bloods. So instead of healthy balance, they quickly take the insulin and other medicines. Yes, please. So that was my really beginning, the right to a healthy future. Once I participated in the IDF, International Diabetes Day in Brussels, and this vision, our right to a healthy future, gives me the power, the motivation, and the responsibility for myself, my family, and my society to keep distance from diabetes, to be aware to my role as a leader woman, to give strength to other group of women instead of crying, instead of being not strong, being weak, and waiting just for the insulin by the times and by the years. So if you see, we have women from different countries around the world that have a power to give the others societies and other families a strength to move and be aware to their situation. Yes. Women lead change. This group of women, I teach them, empower them in order to give them the facilities, strategies, knowledge, help in order to understand their role in managing the family, because women do take care of the family, the health of the family. It's taken for granted. They become pregnancy and they have child. So I will talk about these women also by a film that I prepared. They are Muslim women, conservative, from a small village besides the beach, which is called Jisr al-Zarqa. These women take the first session of course before coronavirus the first time, and the next course will be coming in this month, but unfortunately we have a closed country now, so we might have this course maybe after 1 month. Yes, please. So if we back to the IDF, International Diabetes Federation Day, we see the logo. This is the logo, which is from a blue circle. Because of this village of women besides the beach, the sea, so we took the seashells and make this logo for us. And this person who is in the picture is the mayor of the municipality there, who supports women, supports health by all means. So this is the agreement that all sign that we want to be a leader for diabetes preventing. Yes, please. So why women? Women take care of the family, take care of health, suffer from high weights and lack of education. So we empower women to be strong in order to keep life healthy. Yes, please. I think I send another presentation, not this. There's another one. You may open it. Yes, please. Excuse me. So while you are preparing the second presentation, I want to talk about the role of women in leading the health promotion inside the families. Also, although in the coronavirus time, we also make workshops with women in order to keep distance from all the conflict that we share together because of coronavirus. And focusing on women help the societies to be strong and to deal with coronavirus and other difficulties and health complications in good way. Maybe I can go to my screen. May you help, please?
Yes, ma'am.
Okay.
There is another video I can share.
Okay, so I have a video that concludes the activities about women, what we really did from this empowerment course, and participated Ministry of Health in Haifa region, also the Arab Community Organization. So please open the video, let's see it together. Yes, please. Please share it. Okay, as you see, this is a video focused on all the activities that we provide the group of women in terms of empowerment, in terms of health promotion for women. We concentrate on the ability of women to make and lead the change inside the families and their society. And I get appreciation from the Prime Minister, from the President of the state, from the Ministry of Health about this exciting work with women, because every woman adopted the healthy lifestyle and starting to move on inside the family. It was really a great job teaching them and sharing them, because we share the knowledge, we share different styles of life, we learn from others how to treat with our children, our society, school, students at school, and so on. So I would like to Merry Christmas for you all and have a good year, and to be more healthy. We had a very hard year, and instead of being in a real conference, we are meeting online, but still we have the same passion and the same power to make this world better and better, because I will never forget the IDF logo, our right to a vision, our right to have a healthy future. That's in brief. Thank you a lot. Thank you, Dr. Sabu, for this conference and for meeting the other doctors and health promotive from all over the world.
Thank you, Inak, for giving a wonderful presentation. And it was really eye-opening. And I hope more people like you work together and bring females in the forefront of diabetes control. Not only diabetes control, basically you are better half of the world. So you should
Thank you a
lead.
lot.
You should lead. Sandeep bhai.
Inshallah.
I guess namaste and inshallah. And
Inshallah. I was in India. I was in India before 2 years, and I am realized that we should meet in terms of cultures, in terms of people, because I learned from there, from the Indian society, and undoubtedly you can also learn from other societies and other cultures, because we
Very
are a minority in Israel, and the women also is a minority inside the minority. So we lack of education, of healthcare, of scholarship, of empowerment. So when, instead of crying all the time, we should move on. We should learn. We should be on the surface. We need to be. We need to have. We need to live in a good life, because globe is for us to gather. Point. That's it. Corona. Thanks a lot for Corona, because health is for us to gather.
So I think we'll go to the next session. I will invite. She's there. I don't see her. She's there, Sandeep bhai. Our next speaker.
No.
I can't see actually.
It's not surprising if I say that.
One sec.
So, Dr. Anil.
Yes, sir.
So there is a, I think, Dr.
Miss Sonia Sidhu.
Sonia Sidhu
No, Sonia
having
Sidhu.
a recorded lecture, and she had already joined also.
Okay.
Her staff is also joined. So I think she have a recorded lecture, and we can ask the Stuti if they. Hello, can I request someone from RX Events to start her talk, because it is already recorded.
Life beyond diabetes.
Yeah.
મને વિડિયો ચાલુ કરા મારો. Jackie, can you join? Can you join?
Yes, I'm going to join.
Please.
I need 5
Please
minutes
join,
to
because
be able
please
to open
as
video.
early possible, because we are already missing.
After how long I'm going to be on?
No, you can be on immediately, because actually Dr. Sonia Sidhu could not join. She is from Canada.
Oh, can I have 5 minutes?
Please, as early as possible.
Yes, I will be there. Thank you.
So actually, Dr. Sonia Sidhu, she is a member of parliament from Canada, just to introduce her. And I will request Dr. Sandeep Desai and Dr. Anil Kulshreshtha if we can introduce. And then I will talk about her subject. And because her video is not getting downloaded, till that we will get Jackie on board, and then we can have discussion. So can I request Neelam to put on the slide of Mrs. Dr. Sonia Sidhu? Yes. So I request Anil bhai
Okay, sure.
to introduce, please. And then I will talk about what exactly she wanted to talk about, life beyond diabetes. Actually, her video is not getting recorded and not getting downloaded. And then we will talk. And then Jackie is joining from USA. I will just.
So, Miss Sonia Sidhu, as Dr. Vansi has said, she is a member of parliament. She sits on the House of Commons Standing Committee on Health, and in addition is the vice chair of the Standing Committee of the Status of Women. She has a passion for diabetes awareness and prevention, which she champions in her role as the chair of the All-Party Diabetes Caucus. Ms. Sindhu is also the General Secretary of the Canada-India Parliamentary Friendship Group and an executive member of both the Canada-Poland, Canada-Portugal Parliamentary Friendship Group. She further sits as a member of the Canada-Europe Parliamentary Association, the Canada-US Inter-Parliamentary Group, and the Commonwealth Parliamentary Association. She has distinguished herself in Parliament as someone focused on the constituents, health issues, and making life better for newcomers to Canada. Before politics, she worked as a healthcare professional for 18 years, a record that has helped her understand the roots of healthcare needs across the country. She holds a bachelor degree in political science and work as a volunteer on political campaign of all three levels of government. She has a proven dedication to her community, evidenced through her volunteer work and numerous community organizations, including Trillium Health Center. She lives in her riding of Brampton South with her husband Gurjeet, twin daughters Arshia and Amrit, and her son Akash. I will request Dr. Vansi Bhai to start.
Yes, so first of all, thanks, Dr. Anil Bhai, for this kind introduction for Mrs. Sonia Sidhu. She is from India originally, but then she moved to Canada, and she is currently a member of parliament. So she is a very powerful position. I invited her in Diabetes India, and she was closely associated with Dr. Shaukat Sadikot. As you can see, Mrs. Inak also from Israel, and we all met with Inak. I met actually in IDF meeting at Brussels, and with Mrs. Sonia Sidhu, she was with us at Kolkata. So the idea of this empowerment and the education which we were talking from Inak or Sonia, that it is life beyond diabetes to empower the people with diabetes. And we are just not talking about the only diabetes, we are just talking for non-communicable disease to get prevented. And this is actually a voice of a general public which is to be talked in Canadian Parliament. And when we were talking to Mrs. Sonia Sidhu when she was in India, we were trying to get a similar type of advocacy has to be done in our country also when we were talking about the prevention of diabetes. The second time I met again with Mrs. Sonia Sidhu, and she had traveled along with her Prime Minister. I'm sure you will be remembering that Canadian Prime Minister was here in India before some time, almost 2 years back with his family to visit India. And at that time, Mrs. Sonia Sidhu was also there. She was there in Punjab, and she had done some of the big meetings with CM and Chief Minister of Punjab and many more. So the idea was that how we can create a advocacy in our country also to prevent diabetes, to increase awareness about diabetes. Unluckily, in our country, one side we have high number of patients with infection, and other side we have non-communicable disease also increasing. And during this COVID time, when infection started increasing, again the NCDs, which are the major trouble for our country, I mean, again, it was sidelined, and again, we all started talking about the infection. But I think we all missed one thing very important, that infection can occur to anyone, but those who become serious, those who are in hospital, those who died, they were having comorbidity. And one of the important comorbidity which was there with them was diabetes. So I think if we can prevent non-communicable disease, probably we can prevent also the morbidity and mortality because of infection also. And that was an idea of advocacy, a life beyond diabetes, that how we can prevent the diabetes itself, or those who are already having diabetes, how we can reverse diabetes, and how we can make the diabetes free India, or at least delay the diagnosis of diabetes. Now, few things are to be done. One is we want women empowerment. Why we should have women empowerment? Because if we can educate them, as Inak was talking about, the diet issue is a very important thing. The second big problem is, other than nutrition, which we are cooking at our at our home, which is if unhealthy, probably we are making complete family unhealthy, and they are becoming more prone to develop diabetes and non-communicable disease. But second important thing, we want to have the next generation should have a normal baby. That is what we are looking for. We should have our children, they should grow fully, they should next generation should have a normal birth weight child. The newborn should come with a full term, and they should have a normal delivery rather than cesarean delivery. And third thing, in their school itself, we want to create a health science, a booklet on health science where we can educate them. Inak is actually a health educator. She teaches in school, she teaches in college, and and she is a brand ambassador for health education in her country. The similar type of advocacy we want to have in our country. When she was here, she had given the talk at Delhi, Agra, and Jaipur. We could not have her in Ahmedabad, but next time, probably when COVID will be over, we may have Sonia and Inak to our city also. But the idea is that how we can improve the child health or pediatric diabetes or pediatric obesity, which is a big problem. And in India, we started one project which is under RSSDI idea with the help of Public Health Foundation, which is kids program, knowing diabetes in children. So I mean, that's a very important program to prevent diabetes in future. And the third important thing about other than diet and this, I think exercise, which we are completely lacking. I think the sedentary lifestyle, there is no place where person can walk and no gardens. So these are few things where the administrator can help us. They can improve the public transport. They can help us to improve the people should walk on the footpath. They have to create a good walking areas where people can go and walk and they can do exercise. So if we can create all these things, probably in future we can think of decrease in non-communicable disease. And first, very foremost important thing which I had put to the government, that one is health science booklet should be the part of education curriculum. And second very important thing which we had talked to them regarding that we should have a habit of standing more rather than sitting more. So if I just remain standing throughout the day, my physical activity will increase, and probably that will increase my consumption of calorie, and chances of central obesity will decrease significantly, and that will also help in decrease in diabetes or in communicable disease. With these few words, now we have the last one from Dr. Jackie. She is again from a Lebanon. She is will be again for the empowerment. She is representing the country Lebanon in International Diabetic Federation. Currently, she is in USA. So for her, it is early in the morning. And hello, Jackie, how are you? And now I request Dr. Sandeep Desai to introduce her, and then we will have her talk. So can I request Stuti or Neelam to share this slide of Dr.
Yes,
Jackie?
good morning.
Yes, good morning for
Good
you,
morning,
and it's
everyone.
good evening for
Good
India.
afternoon.
Yeah, good
The
morning,
rest
Dr.
of you.
Jackie. Yeah.
Thank you so much for
Jack,
having me with you today.
yeah, thank you for coming.
Okay,
And
somebody else, it seems, is sharing a screen, so it's telling me I cannot share a
No.
screen.
So
I'll just introduce you.
Dr. Desai to introduce you, and then you have to share the screen. Okay.
So,
thank you so much.
A brief introduction of Dr. Jackie Kossoff Malouf. She's a founder and president of DIALEP, the National Diabetes Organization, a leading diabetes organization in Lebanon, and which she founded with her daughter Sylvie, living with type 1 diabetes in 2010, and has been the president since. She holds a PhD in public relations and communication from the University of College in Virginia. She made it her mission in life to advocate for those living with diabetes and delivers educational and motivational talks, especially to the recently diagnosed. She has 10 years of experience in leading the NGO's awareness campaigns and activities across Lebanon, and she holds a diabetes educator certificate and participated as speaker at many local, regional, and international diabetes conferences. Prior to running DIALEB, Dr. Malouf taught at the American University in Beirut and the American University of Culture and Education, and continues to offer training sessions in different topics. Dr. Malouf has been an active board member of the Lebanese American Renaissance Partnership LARP since 2014. Her book appearances include The 100 Most Influential Lebanese Figures Around the Globe, published in 2017, and Women Pioneers in Lebanon and the Arab Region, published in 2010. Dr. Jackie, you have a lot of experience, and we are very honored to have you here on this dais, and you can go ahead.
Thank you so much. Allow me really to thank the organizers of DiaCareCon for inviting me to be with you. It's really an honor. to be speaking about this topic, which is very dear to my heart. You've all heard that I have a daughter with type 1 diabetes. So I think it's a life mission for me. I hope to take advantage of these few minutes to discuss very important topic, which is the diabetes education. And we all know it's a key to, 1 second, I need to fix my screen. It's a key to preventing diabetes complications. What I'm going to be discussing today is few diabetes education facts, the role of education. Of course, we're talking diabetes education, the role of NGOs, being myself a president of a diabetes association or an NGO in Lebanon, the role of NGOs in diabetes education, and the NGOs activities model. And I'm going to be talking about Dialab, an association which I'm very honored to be the president for the last 10 years since its foundation. A very short literature review, and then a diabetes survey by Dialab. It's our first study. It's not published yet. I'm going to be sharing with you a few of the results, and then conclusion and take-home message for our attendees. So if we're gonna be talking about few diabetes facts, we know that in today's world where the health challenges are bigger than ever, greater than ever, we come to realize even more than ever the importance of education and its role in the prevention, treatment, and especially management of diabetes to prevent the complications. Of course, we all know that diabetes is a very serious and life-threatening disease. However, it can be well managed through proper treatment and control. And when I said about today's challenges, of course, I mean the pandemic and the more challenges than ever that we are facing. We hear a lot recently about diabetes self-management education, DSME. It plays a vital role in the management of diabetes. It is crucial for the patient, especially, to be aware of the nature. What is my treatment? What are the doctors giving me? About the risk factors, and most importantly, the complications of the disease. As we see, and we all know, of course, diabetes affects our whole body, many of our organs, and diabetes-related morbidity and mortality are primarily attributable complications, many of which can be potentially delayed or prevented, which means, in other words, it's a shame to have someone lose a limb or lose his or her sight if we can prevent that. That's where the role of education it plays in the prevention of diabetes itself and in preventing the complications. The education plays a role in early detection and diagnosis of diabetes, in the enhanced management of the disease itself, in better outcomes and therefore prevention or lower incidence of complications, and definitely, and most for all, better quality of life. Diabetes education must be targeted at different audiences, and this is what we're going to be talking about, educating the community, educating the patients, and educating the professionals. And we don't mean by that that the professionals don't know, but maybe they don't know enough about diabetes. So we know that this is the year of the nurse, and nurses are in many cases the only medical professionals that many patients see. So nurses should have enough understanding of the warning signs. So if they see those signs, they should refer the patient to the specialist or anybody from the medical care who could take care of them. Nurses and diabetes educators must understand the disease and its implications in detail in order to effectively and efficiently support their patients. We've seen cases when students come to our associations to do internship. Let's say they are a senior year studying nutrition. they have a minimum knowledge about diabetes. So we don't want our future professionals, let's say our future dietitians or nutritionists, to stress on making people losing weight. We want them to stress on making them live healthy, to prevent diabetes and other diseases. And if they don't have diabetes, to help them live healthy, to prevent those, and if they have them, to manage them in a better way. Diabetes education must be, again, targeted at different audiences. Here is the key point. The diabetes patients, they need to know what's going on. I've seen it many times during our awareness campaigns. They don't know what is the medication. They need to call the daughter or the son to take a picture of it to tell us what he or she are taking as medication. Most of diabetes management is self-driven. So this is a must for the patients to know not only what medication they are taking, what is diabetes, what are my risks, what am I facing, what am I up against if I continue with the trend, let's say if I have a high HbA1c. So the patient is left to make proper lifestyle decisions, which include taking the recommended medications, incorporating exercise, making nutritional choices, and with that they need help. Education is key to support patients in making those right choices. For type 2 diabetes, and it is the majority, 90 to 95% of the total cases of diabetes in the world. So we are talking about huge numbers in our populations. Education can be a catalyst in lowering the rising rates of the disease in type 2 diabetes. Diabetes education is an important component of diabetes treatment, and the goals include providing information, but not any information, the proper and accurate information and knowledge to enable patients to self-manage better. Changing patient behaviors, we all know this is the most difficult part, and the patterns, and talking here about lifestyle, changing the way they eat, and motivate them to do more physical activities, not necessarily to run a marathon, but to be active. Also, the goal is to support patients to comply with medical and nutritional recommendations. Again, I've seen it a lot. Some patients say, I heard insulin makes me put some weight on, so I decided not to take it. It's not a decision of the patient. They need to comply with what the doctor indicates in those cases. And here is our message for today. Education is key in preventing complications. Keeping blood sugars in range is key to avoid potentially deadly complications of diabetes. People with blood sugar levels closer to normal, and this I've seen it in many studies. I'm not going to name them because you're all aware of that. Those people have fewer complications. When the sugar is well managed, we at least delay, if we cannot prevent, all the complications. Managing blood sugar levels involves continuous monitoring, making good lifestyle choices, and ongoing treatment. Again, talking about type 2 diabetes, it is important for patients to understand that diabetes, if mismanaged, and I have this in bold, only if mismanaged, increases the risk of other diseases. The most common of those diseases is the cardiovascular disease, which can lead to heart attacks or strokes. However, this cardiovascular disease can be avoided, or as I said, delayed by many years, only by taking simple lifestyle changes. If we smoke, we need to stop smoking. We need to watch our diet. What we are eating affects our health, and to lower the A1C levels. And here's again a key point. Some patients consider it a mission, impossible mission, to lower their A1C. They need to be educated and understand that if they lose 5 to 7% only of their body weight, they can lower the A1C by 1 point, and we all know how important this 1 point is. How important is diet and exercise for type 2 diabetes? Diet and exercise are the foundation of diabetes management, the key, the pillars. However, the common public does not have the necessary knowledge of nutrition to make the right dietary choices. Let's say many people ask me, what is the diet for people with diabetes? And you need to explain there is no diet specifically for people with diabetes. You just simply have to follow a healthy diet. Good for me, good for you, good for someone with diabetes, and for everybody. But they need help to make those choices and to understand what is a healthy lifestyle. Traditional foods and ways of eating are not always conducive to diabetes management. So here again, they need the help of a professional or someone from the Diabetes Network Care to be helping them take the right choices. And we all know about today's sedentary lifestyles, and those are not helping. They are making people lazy, they're lowering the exercise and physical activity, which is not good for our health. It is important to educate people about the importance of exercise and the need to introduce it in their daily activities. And most of all, in our education ways, we need to make things simple. We need to understand that people from the community living with type 2 diabetes, and again, I've seen that a lot throughout our awareness campaigns, they need a simple language, nothing complicated. They need to understand what are the steps in a very easy way. I start talking here about the role of NGOs in enhancing diabetes education, and that is absolutely a continuous process. We don't do it today and stop it tomorrow. Patients need continuous information and reinforcement. Many of the concepts of nutrition in diabetes management are new, and therefore they cannot be learned in the 15 minutes visit to the doctor. We all know that the doctor wants and have the goodwill to help the patient to the maximum. But let's be realistic, the 15-minute or 20 minutes doctor's visit is not enough. And that's why education should be continuous. NGOs and diabetes educator can play a key role here to fill the gap. So NGOs can provide continuous education and diabetes awareness to fill this educational gap. Talking again about the role of NGOs in enhancing diabetes education, I'm going to mention the role of Dialab, which is a leading diabetes organization in Lebanon, founded 10 years ago. I'm going to mention only our educational programs because we're talking here about the importance of education. First and foremost, the patient support sessions. Psychosocial support, peer experience, this is very important to give them the tools they need and the moral support to go on. They need to understand I'm not alone, especially those living with type 1 diabetes, and I've seen it amongst our members. And allow me to mention here that after the unfortunate Beirut blast in August 4, we've seen a lot of depression in people, especially in those with diabetes. Add to it the pandemic and the fear of getting COVID-19 and not knowing what the nasty consequences may be, especially for those with diabetes, having the contradictory information coming out every other day. We really needed to do very frequent support group sessions for our members in order to help them stay sane in this difficult situation, as we've had a lot going on in 1 year. Prevention and general awareness are in the core of our mission at Dialab. We have a program called Diabetes in the Classroom for schools and universities, as we believe education should start at a very early age to allow our children and youth to lead healthy lifestyles. Diabetes in the community targets mostly people with type 2 diabetes, and most of them or some of them don't know they are living with diabetes. We do know that. And we have the internship programs, and here we believe in educating our future professionals, letting them see firsthand what they need to do when they become our professionals. Educating the educators, and here I mentioned the scientific conferences like we do every year on the occasion of World Diabetes Day. And of course, that is all with the support of our scientific committee. We address it to doctors, nurses, dietitians, fitness instructors, and diabetes educators. Promoting exercise, those activities include marathons, exercise sessions, hikes in nature, and this is a very simple and easy way and fun way to motivate them to lead those healthy lifestyles. I'm sharing with you a couple pictures to let you know, but I'm going to mention here that some of the topics we insisted on during last November, where we intensified our campaigns on the occasion of World Diabetes Day, we addressed mainly dietitians and nurses in believing that they need to broaden their knowledge to better handle their patients when those patients are living with diabetes, whether type 1 or type 2. I mentioned to you the patient education session and the patient support groups, and those are very much needed. When I mentioned continuous information and accurate and proper information, I'm sharing with you here the issues of our Dialab Review magazine, which is used to be distributed free of charge. We stopped this year, 2020, printing it, and now it is only available online, downloadable version, of course. In it, you can see from many professionals, it's like a 90 pages magazines, both in Arabic and English, to make it easy for all our viewers to see and understand and benefit from the important information. And all the people you see on the cover are real people. They are our members living with diabetes. And if you look at the this one, I don't know if you're seeing my cursor. This is my daughter Sylvie with her 2 boys, and she is really a motivational speaker and motivates many of our members to go on, as she is a married lady. She's living with type 1 diabetes, managing well her diabetes, and she is also our managing director at Dialab. All the activities that I mentioned are working toward the goals, the sustainable development goals of the UN. Especially, we focus on goal number 3 related to good health and well-being, and goal number 4 related to gender equality. As we all know, diabetes touches equally men and women. A very short literature review, something that called my attention related to preventing diabetes complication through education. In a study published in 2005 in the medical journal, the extracted data indicated the importance of diabetes self-management education, again the DSME, in the promotion of health practices that could prevent or delay potential diabetes complication amongst persons with type 2 diabetes. But I would like to mention here that this study speaks about type 2 diabetes, but also for people living with type 1 diabetes, managing well their diabetes, understanding well the disease helps them prevent all complications. Another study published in 2009 by the American Diabetes Association, ADA, highlights the importance of education in preventing and delaying the onsets of diabetes. And here's the study I mentioned in the beginning of my presentation today. This is a study that Dialab did. It's a survey actually, and now we have the data analysis of the survey. We conducted this survey across Lebanon, and we gathered information about diabetes. It was a bit broad. We had 18 questions in this survey, and it was distributed to public from all ages, all demographic areas. We also had our members participate in it, and some of the results reflect that. I will share that later on with you. Our sample was 2,000 participants. It was between the year 2018 and it stopped 2020 early stages, and now we are analyzing the data. Something that called our attention, and I wouldn't really stress on the percentages because a big number of our members did the survey. So of course we see a 24% in type 1 diabetes, but this is not really the reality of all Lebanon, as prevalence was not our target. We were looking for other things in this. But what I would like to stress on the most, since we are talking about diabetes education, we did ask different questions related to how you are managing your diabetes, what type of medication, oral or insulin or both, how do you monitor your blood glucose sugar, and we came up with some of the results that really called my attention. If you look with me at the first line, type 1 diabetes, it's 56% only shows insulin and 22% said they were taking pills. Now, of course, we do know that someone living with type 1 diabetes cannot manage taking pills. So this is an eye-opener that either those people most likely did not know the difference between type 1 or type 2 diabetes, because it's actually impossible to have this high percentage of people taking pills and living with type 1 diabetes. We also noticed that only 4% of those living with type 1 diabetes are using the pump, where others prefer to do the daily injections and not use the pump. 17% of those living with type 1 diabetes are taking both oral medication and insulin injections. And in the other questions, also we noticed that taking the oral medication was mainly to help them lose weight in order to better control their A1C. In those living with type 2 diabetes, we noticed that 12% only are taking insulin, which is good, as we want them to rely more on making an effort in doing exercise, changing their lifestyle. And we have only 4% that you see here without medication or insulin. This is what I think we need to be stressing on to educate our population to rely more on their own efforts to control their diet, to do a little bit more physical activities in order to control their diabetes, rather than to take so many medications and then at the end add the insulin to it, which I'm not saying is wrong, but if they can live without it, then it's much better. Pre-diabetes also was an eye-opener for us. We all know that everybody nowadays is stressing on the importance of educating people while they are in the pre-diabetes stage, because at that stage, they can have it reversed. We see here that 80% of the people who said are living in the pre-diabetes stage, 80% of them are taking pills, whereas only 20% are living with no medication at all. This is also an eye-opener, and I think we need to stress more on educating this segment of the population so they can do the extra mile and they can understand better what are the simple steps that they could change in their lifestyles in order to better control the prediabetes, reverse it, and not become diabetic patients in the future. Of course, we have many more results in the study. I only shared a few points and few slides with you. We are going to be publishing it soon. The conclusions and the take-home message is, first of all, we must become more involved and perform our essential role to save the lives and reduce healthcare costs. We know that the complications are the highest cost of diabetes everywhere in the world. I'm not going to go through numbers, but I do know, let's say here in the US, where I am now for the holidays, they have the budget for diabetes and diabetes complications is higher than the budget for cancer. Dialab has made it a priority to inform, educate, and assist patients, caregivers, and communities through our multi-channel awareness and prevention programs. Most importantly, we aim to improve the quality of life. This is a very tricky point. It's not a matter of surviving diabetes, of living with diabetes. It's the quality of life that we need to pay attention to. And we like to help our members and our patients keep their diabetes under control to prevent the complications. The cost effectiveness of diabetes self-management training or education, DSME, and medical nutrition therapy to treat diabetes are being adopted by more patients association as well as care centers, because the results are obvious if we see all the studies done on this topic. The value of patient education is evident from research demonstrating that patients who never received diabetes education are at increased risk of a major complication. So the key is in our hands. We see the results of the studies. Those who have not received diabetes education are at higher risk. We need to educate more our populations so we lower the risk of the complications. The basic objectives in the handling of type 2 diabetes mellitus patients are reaching normal metabolic control and preventing complications. At the end, I would like to say that the intensive efforts to increase awareness amongst health professionals and individuals living with diabetes to improve diabetes management through education are urgently needed. I'm not saying it's not happening, but they are urgently needed to be more spread, more into our population's mind that they need to be educated to control the increase of diabetes, as it provides a useful benchmark to plan future strategies in diabetes care. And at the end, the COVID-19 pandemic makes it a must to double all efforts and to pay more attention, especially to mental health. I'm mentioning this because, again, we've seen it amongst our members. This side should not be neglected, and it should be an essential part of educating the population, educating the patients, and educating the professional teams, the mental health side on top of all the other informations. I would like to thank you for listening attentively to what I had to share with you. Here is our social media portals where we put all the information that our professionals and our scientific committee work very hard on. And thank you so much for inviting me again. Allow me also to wish everyone happy holidays and healthy holidays. Let's all hope that next year is going to be better for all of us.
That we need to ponder about. And this is more important because if you look at the projected increase of death,
Thank you, Dr. Jackie, for giving this
it has increased from 54% and it is close to about 54%.
I'm sorry, I'm hearing in the background another presentation.
And the main cause of
First of all, let me congratulate you for the work which you are doing under DILAB. It is wonderful to see.
Thank you.
Putting so much of effort, and I think results are showing. And you have given a wonderful presentation. It has opened eyes of all of us that we should have more focus on education actually. Dr. Bansi Bhai is there. I think he will like to say
Yes,
something.
I am very much there, you know.
Yes, sir,
Jackie, for a fantastic talk. A big round of applause for Jackie and
so
Inak, and I can see Shiru and Aina. This is all, you know, the international ladies who are empowering women, and at the same time, they are also doing a lot of advocacy for diabetes, and all of them are very active in International Diabetes Federation. And I just try to, you know, invite all of them on one platform. So we have from Canada, we have from Lebanon, we have from Israel, we have from our Southeast Asia, Maldives, we have from Ukraine. Aina is there. I don't know why she is not showing her face. And now she is also in Oslo. So, and then we have Tajana. She's again from Macedonia. I was there at Macedonia long back, 2 years back. So the idea was to keep, and you know, the education is very, very important part of it. And advocacy, education of the patients, family, caregivers, the government. So that is what the reason why we had kept this particular session. The session was for lifestyle modification. And I'm sure those who have listened Siru and, you know, those who had gone Maldives, they can understand how difficult it is to treat all those type 1 and type 2 diabetic, where they are coming from a small places, and then they have to come to their I mean, I can't say even that city, it's a small, again, even more island where they have to come to take their insulin, and it's real it's an amazing country, and the Shiru is working very hard for taking care of all those type 1 and type 2 children. And Aina, she was in Ukraine. I was there with her also in Ukraine, and now she is in Oslo. That is what I heard. She is currently Vice President of International Diabetic Federation. So the idea was to include all of them in an education program. That's very important. Just to share with all of you that this year DiaCareCon because of our digital platform, we have reached to 30,000 delegates. So 30,000 delegates are registered. Just now we have 7,000 doctors who are already listening us. So in different hall, we are having 3, and your particular hall, more than 1,500 doctors are already listening from all across the country. Many of the doctors who are registered from Far East, Middle East, African countries, Southeast Asia, also because registration is free. And all the lectures are also simultaneously streamlined in Facebook. So live on Facebook live also we are there, and they all will be remained, I mean, recorded lectures, so you can listen anytime if you have missed anything on our website. This platform will also live for another 2 months, so they can listen anytime, whenever they want. Whenever they want, the Jackie talk was very good and they want to listen, they can again go and listen the same talk multiple times. Everything is recorded. I will be sending you the link also, so you can share this link with your friends, your colleagues, your relatives. So I mean, anytime they can listen all the topics and all the talks. And still you can join for our main hall, that is orations, which we are going to have. At present, the session is going on with SGLT2, and another hall it is on GLP-1. Both of these are newer anti-diabetic agents. So we are moving from education to therapy. Your symposium was little early. We are closing because we could not download Mrs. Sonia Sidhu presentation, the video which she sent, and we could not have her live on this session. So for that, I'm sorry to all my delegates friend and all my colleagues who are here. If you have anything to add, Dr. Sandeep or Dr. Anil. Dr. Anil is an eminent physician and consultant from city of Ahmedabad, from where I am. Dr. Sandeep Desai, a close friend of mine who is from south of Gujarat, from Valsad, a city called, and they are chairperson. Dr. Dharmendra Panchal, who is with me and taking care of one of my other clinic, which is DiaCare. You can see on that's a DiaCare clinic only, Dr. Dharmendra Panchal. And so just to introduce you, because may not be knowing many of you, Dr. Meet Shah, who is also there with us, is also working with me. So with these few words, if anybody wants to make any comments, most welcome. Otherwise, we can close this session.
Yes, please.
I
Can I
think
say
Jackie,
something?
yes, Jackie, please.
Well, I'm really sorry that this has to happen virtually, because I've been meaning to visit India for a long time. So hopefully next time it will be in person, and it will be a pleasure to visit this beautiful country, as I have many, many friends. And I would like also to mention something else, that my daughter has been living for 14 years now with type 1 diabetes, and going step by step throughout that process, and seeing that she is a very well educated lady, highly educated, highly professional, and now a mother of 2 boys. And still she has to really make extra efforts, go the extra mile to control her blood sugar. This is a call to everyone who's attending. If they are living with diabetes, there is a phrase she says that I think touches me a lot. She always tells me, diabetes can be your friend if you control it, but it can become your worst enemy if you let it take over your life. And I think with this, I would like to give a message of hope that yes, we do need to do a lot. Yes, education need to be spread wider. Yes, the diabetes complications are not nice. No one would like to live with them. All these are facts, but there is always a message of hope. That's why we are here spreading this message of hope to all those living with diabetes. Take control of diabetes. Don't let it control your life. This is my message to you, especially in these holidays as we are living a Christmas season. Wishing you all the best, very healthy 2021, hopefully to you and to all the attendees who are listening to us. Thank you so much.
So Jackie, I mean, when you are talking of type 1, I'm sure the Shiru would like to make comment, because she is taking care of these type 1 children in the Maldives. And you please visit the Maldives, the most beautiful country I ever visited.
Yes, absolutely.
And then definitely Aina would like to make some comments, because if somebody is talking about type 1, I'm sure that Aina would like to make some comments. She is currently Vice President of International Diabetic Federation. So I will request both of them. And then we have downloaded the video of Mrs. Sonia Sidhu also. So then we can play immediately after that Dr. Sonia Sidhu's video too. If Shiru, you want to make any comment, and then I can request. You have to
Yeah.
unmute.
Yeah,
Yes.
I have. Yeah, I just want to thank you, Dr. Banshi Sabo, for this invitation. And then I am really impressed that this panel consists of all women. So I'm really happy to see that, and I'm proud that we are taking this initiative, and the women are in a position to lead this type of programs. And I'm just proud to say that in my country, our NGO now has an all-women team who is doing all the
Kim,
work.
nothing of that, Akash?
So thank you so much,
Kaya
and
natin ko?
you a better year 2021 than 2020 for all of you. Thank you, Dr. Sabo.
I just few words want to add.
For this lectures, for this conference, I do appreciate all of you. Hope very happy year, a healthy year for us, for all the persons, all the cultures around the world. Just to remind that diabetes is a silent killer, silent sweet killer, and hope that we will meet in the next coming conference by face and face and share our cultures, knowledge, and the leadership of having a healthy future. Thank you a lot for all of you.
Dr. Edna, you can.
Thank you so much.
Edna, you want to?
I would like to say big thanks to all of you, because I was very happy to be part of your conference. And I say before that our session's the best because a lot of attractive women.
No doubt.
We were the only odd man out.
Odd man out.
All ladies,
And-
we were the chairpersons
Yeah,
for the odd
only
men.
I think great chair of program this. It's very good point. And but if it's seriously, I'm very happy that I see a combination and collaboration between healthcare professional, a doctor, nurse, and educator, and pharmacist. I'm pharmacist, and as patient and diabetic association. There's very important role in as NGO in life of people with diabetes. My diabetes start with from I became leader from my diabetic association, Ukrainian Diabetic Association. I was very happy that I was involved many years and became strong and don't. And if I speak about discrimination, I never feel in discrimination because I was involved in diabetic movement and can be proud and sure. This is we can our patients.
Oh yeah.
That's all.
Go.
Merry Christmas to all of you. Stay safe and healthy. Thank you so much.
Merry
Thank you
Christmas.
for
Thank you.
our chair of our session. Thank you so much.
Thank you, everyone.
Anil bhai.
Thank you.
Last
Bye.
word.
Neelam, you can play the video of Dr.
Yeah, okay.
This, and then other can, yes, sure.
Chair of our Parliament's all-party caucus on diabetes. As you all know, we are going through some challenging times together as a global community amid COVID-19. 2020 has been a year that at times has brought us together, and a year that has challenged the world in so many ways. Despite that, I'm so honored to be with you virtually today. Canada and India share a strong relationship, people-to-people ties, and great economic and business cooperation. We also share the understanding that diabetes is a public health priority that must be addressed worldwide. I'm proud to be a part of a government that also recognizes this and values India as an important partner for Canada. I would like to thank you for being here today, as well as thanking Dr. Banshi Sabu, Chairman of Jia Care Con, for organizing this event. I'm thrilled to be with such like-minded people working together to celebrate important moments in the treatment and prevention of diabetes, a disease affecting over 442 million people worldwide. In order to understand where we are going, it is important to look at where we have focused research attention. In Canada, federal health research is conducted by the Canadian Institute of Health Research, within the CIHR, the Institute of Nutrition, Metabolism, and Diabetes identified three strategic priority areas for research. The first relates to food and health. Through this priority area, the INMD supported research on nutrition practice and food policy. This includes understanding the whole diet and specific nutrients which could reduce the risk of chronic disease. Under the new healthy eating strategy developed by Health Canada, Canadians are encouraged to look at food through a nutrient-based lens rather than caloric or food grouping categories. The second priority area was environments. Genes and chronic disease research in this area looked at the influence of environmental and genetic factors on chronic disease within Canada. We know that some populations are at high risk of developing diabetes than others. These include Canadian Indigenous populations, especially those in remote communities and the far north where food security is an issue. Additionally, South Asian population in Canada face higher than average rates of diabetes. In my community of Brampton, we are seen as a hub of diabetes, where 1 in 6 people have diabetes or prediabetes. A recent tour of a new medical facility in Brampton revealed that with dialysis machines running day and night, a high proportion of users are of South Asian heritage. Understanding environmental and genetic factors will contribute greatly to our ability to combat diabetes in Canada. Finally, the third priority area identified was obesity and healthy body weight. This research focused on solution-based intervention to obesity and provides clinical policy and population health insight. Working with the partners in Canada and looking to best practice around the world, this research sought body positive population health solution to reduce obesity rates through working with partners, mobilizing health research, and reaching for excellence within the organization. We are on our way to better health for all Canadians through an inclusive process. Canada has a remarkable legacy of leading discoveries in diabetes research. In 1961, biophysicist James Still and cellular biologist Ernest McLaw from the University of Toronto discovered stem cells. Although it was not fully appreciated at that time, their research is now considered to be among the most important medical findings of the past century. Decades after its discovery, stem cells technology is still in fairly early stages, but there is a hope that it will lead to real cures for anything from cancers, spinal cord injuries, rare diseases, and of course, diabetes. 20 years ago, Dr. James Shapiro and researchers at the University of Alberta developed the Edmonton Protocol. Just last month, Dr. Shapiro and his team encouraged that they had made strides toward a cure for type 1 diabetes by transforming blood cells from patients into insulin-producing cells, which can then be transplanted back into the patient. If successful, the technique would bypass the need for anti-rejection drugs and possibly keep patients from needing lifelong insulin injection to survive. Of course, Canada's most significant contribution to diabetes research is the discovery of insulin in 1921 by Sir Frederick Banting. Dr. Banting, a surgeon at the University of Toronto, conducted research on the pancreas, an organ known at that time to produce digestive fluid and to play an unknown role in regulating blood sugar. Instead of profiting from their monumental discovery, they donated the patent to the University of Toronto, saying no one should profit from a life-saving medication. In recognition of this achievement, in 1923, Dr. Banting and Dr. McLeod were awarded the Nobel Prize in Physiology and Medicine. We know that with the proper education, the risk of this disease can be reduced. That is why I'm proud to say that I successfully led the effort both nationally and in my home community of Brampton for November to be recognized as Diabetes Awareness Month. And I have introduced Bill C-237, which directs our government to create a national framework for addressing diabetes, which I'm proud to say is getting support across the political spectrum. Bill C-237 mandates that our Minister of Health work in collaboration with provincial health leaders, indigenous communities, and other stakeholders to develop a national framework designed to support improved access to diabetes prevention and treatment to ensure better health outcomes for Canadians. The All-Party Diabetes Caucus consists of a group of Canadian parliamentarians who are interested in and dedicated to improving the health of age of the 11 million Canadians living diabetes and prediabetes. We agree that we must continue to fund research and make strides towards overcoming this disease and have made much progress, but there will always be more work to be done to ensure that all Canadians have the highest quality of diabetes care. I also serve a member of the Standing Committee on Health, which studied diabetes across Canada in depth in 2019. The Health Committee also heard some shocking stats about diabetes and Indigenous communities. Diabetes rates are 3 to 4 times higher among First Nations than among the general Canadian population. And many Indigenous peoples are at increased risk of developing diabetes. Furthermore, Indigenous individuals are diagnosed with type 2 diabetes at a younger age than other individuals. Those living in a First Nation community who are in their 20s have an 80% of chance of developing the disease during their lifetimes, compared to 50% among the rest of the population of the same age. The global prevalence of diabetes is 8.8%, and this rate is expected to increase worldwide largely as a result of the aging population and increasing obesity rates. Canada gave insulin to the world, and I'm proud to say that we continue the fight against diabetes as we work to give the world a cure. Next year, Canada will celebrate a milestone of Sir Frederick Banting's discovery. Last month on World Diabetes Day, I had the opportunity to visit the house where Dr. Banting grew up in London, Ontario, where we rekindled the flame of hope, symbolic torch which has burned since 1989 to honor his discovery of insulin, and which will only be extinguished once we find a true cure. I think we can agree there have been many advances made in the treatment of diabetes, but there's still much more work to do. Together, conferences like this and the work of all of us here brings us closer every day. Each of you is working to discover the next moment in diabetes history, and we can all work together to find a cure. I'm confident that one day soon we will once and for all extinguish the torch outside Banting House. Thank you for inviting me and including me for the opportunity to speak. I would like to wish everyone a happy new year 2021. I'm looking forward to continuing to learn from and engage with all of you. Thank you so much.
What are the 5 key benefits which leverage the...
Hello.
Hello.
I think we can close this session.
Thank you, everyone. Thank
so
you.
if we have anything else, thank you
We just want to
once
say
again.
happy holidays and happy new year to each one of you.
Happy New Year to everyone.
Thank you very much for giving this.
Merry
this
Christmas and Happy New Year in advance.
Thank
Enjoy
you.
and let us have the next year. Thank you.
Thank you.
Bye.
Thank you, Bansi Bhai, for giving us this.
Bye.
Bye.